compassion prayer for our health workers. Heavenly Father, grant us your mercy and grace. Bless the works of our medical experts who have dedicated their lives attending to the afflicted and suffering. Keep them safe, together with their families and loved ones. Bless all our medical experts at the forefront of this critical mission, that through their presence and care, the world may see hope and experience your divine love and healing. We ask this in your mighty name. Amen.
What if employees are not comfortable talking their concerns about their safety culture to their managers?
The best organizations actually has to have an open flow of communication, and management is also willing to address their safety concerns.
If you will be running all the tests for ISTAT, which one do you need to prioritize?
So if you are going to run your CG4, Chem8, and your troponin, ideally you should always start with your CG4.
Transcatheter aortic valve implant. How did you specialize in this practice?
There's no specific training that you need to take to specialize in that one, as long as you attend a study day.
In behalf of the organizing committee of the 4th Critical Care Summit for Nurses, thank you for choosing us as your partner for professional growth. Sit back, relax, enjoy, and learn with us. Again, thank you very much.
Welcome back, everyone. Good morning. We are on the second day of 4th Critical Care Summit for Nurses with the theme World-Class Filipino Nurses on the Forefront of Healthcare. This forum is made possible by Delex-ICU International Incorporated through its ICU Forum for Nurses. My name is Brad Pete, and I'll be your host this morning. Your microphones are muted by default, except for the panelists. The same goes for your videos. For your questions, just type them in the Q&A box, and our speakers or the organizers will be glad to answer them. For more forum guidelines, please watch this. Delex-ICU Forum House Rules. As working professionals, let us show respect while the webinar is ongoing. Avoid using the chat and Q&A boxes for concerns and comments not related to the lectures, such as e-certificates, etc. And please refrain from using foul words. You may send us a private message on our Facebook pages for concerns at Delex-ICU Forum or at Delex Pharma. Let's show decency at all times, whenever and wherever we are. The certificate will be sent to the attendee's email within 15 working days. Only those who registered and attended via Zoom will be issued with an e-certificate. Don't leave the webinar session without answering the evaluation form. A QR code will be flashed at the end of the webinar. The evaluation link will also be posted in the Zoom chat box. Failure to answer the evaluation form means no e-certificate. Attendees' requests for the evaluation form, post-tests on our FB pages, and email will not be entertained. So, please do not leave the session without answering the evaluation form. An attendee will only avail of an e-certificate if he/she stays at the webinar session not less than 60 minutes. Registration is not allowed while webinar is ongoing. You can still learn with us via our FB Live. When joining the webinar, please secure a stable internet connection to avoid being logged out from the webinar. Concerns regarding internet connectivity will not be entertained. When to follow up the e-certificate. An attendee may follow up an e-certificate if he or she did not receive it on the given period of distribution. The certificate will be sent to the attendee's email in 15 working days. An attendee may follow up when he or she has answered the evaluation form, post-test, pre-test. If a participant did not comply with the guideline, the concern will not be entertained. Reasons why an attendee may not receive the e-certificate. The provided email in the evaluation form is invalid. Make sure that your email is active, free from typographical error, free from unnecessary characters. If an email is invalid, our message to the recipient bounces back. We also advise that an attendee will make sure that his or her inbox is not full. This may result in bounced emails. Thus, an attendee will not receive any email from us. The attendee did not answer the evaluation, post-test, pre-test provided during the webinar. Please answer it before leaving the session. To formally welcome us all, I would like to call on Delex Pharma's Associate Device Manager, Mr. Rian Carlo de la Fuente.
Greetings of love and peace to everyone all over the world. I'm Rian de la Fuente welcoming you all to the 4th Critical Care Summit for Nurses with the theme, World-Class Filipino Nurses at the Forefront of Healthcare. It's a pleasure to have you again for today's session. Yesterday made us realize that your willingness to learn will help advance our healthcare system. We appreciate your time in support this free continuing medical education. The presence of each and everyone is valuable to Delex-ICU Forum. As we open the second day of our webinar, I would like to acknowledge the unending support of our Program Director, Dr. Larry S. King. Like us, he is proud to tell the world that we are more than ready and braver to face any health crisis that may cross our path with the help of our brilliant speakers sharing their insights. May the research and evidence-based lecture be your instrument in achieving greater heights in your respective fields. To our nurses, you are all extraordinary individuals who are very vital frontline workers, displaying courage, care, and commitment to your patients every day. So sit back, relax, and enjoy learning with us this morning. Thank you, and back to you, bro.
Thank you, Mr. De La Fuente. Once again, good morning to our participants all over the world. You're in the right session room. Welcome to our 4th Critical Care Summit for Nurses. I know you're all excited, so I won't keep you waiting. Let me now introduce you to our moderator. He took his Bachelor of Science in Nursing at Remedios Trinidad Romualdez Medical Foundation. He also finished his Master of Arts in Nursing at University of San Carlos, then pursued the Doctor of Management with 36 academic units in Leyte Normal University. Currently, he is the head nurse, endoscopy and bronchoscopy unit at Eastern Visayas Medical Center, the National Vice President for Programs and Development at Philippine Nurses Association, Governor of PNA Region 8 of the Philippine Nurses Association. He is also a member of Philippine Society of Endoscopy Nurses and Attendants. D. Daga.
Alrighty, thank you very much for that kind introduction, Brad Pitt. Once again, ladies and gentlemen, fellow nurses and frontliners, we are still gathered for the second day of our fourth Critical Care Summit for Nurses. Of course, this is brought to us by Delex Pharma ICU Forum, bearing the theme World-Class Filipino Nurses at the Forefront of Healthcare. Yesterday, we already got to hear some of our world-class nurses who imparted their thoughts on some certain topics which I know everyone would find very interesting and helpful. For first up, we heard the talk of nurse Marvin B. Buenviaje about the occupational determinants, safety culture, and compassion fatigue of nurses. Our second speaker was a nurse Ana Marica Fonasher, who gave us her insights about the novel tools for critical care nursing. We also got to hear the talk from our third speaker, Nurse Tracy, about the medications for COVID-19 patients with ARDS, and finally ending day one with a bang, that was Nurse Arsad A. Palinta, who gave us the talk about the topic specialized nursing care for patients with transcatheter aortic valve implant. Wow! Already, so presently gathered is an approximate 5,000 nurses. 5,000 nurses whose hearts are ready for pumping, and of course 5,000 nurses whose minds are in unison, as we go ahead and get to learn from our first speaker for this day too. Our first speaker for today attained his Bachelor of Science in Nursing at the Pines City Colleges. At the same time, clinical nurse intern, master student at the Hospital de Luz and Hospital de San Jose. Clinical nurse intern at the emergency room and critical care unit, master student, Hospital Universitario Central de Asturias. Master in Emergency and Critical Care Nursing joint degree at the University of Oviedo, Spain, Helsinki Metropolia University of Applied Services, Helsinki, Finland, University of Algarve, Faro, Portugal, and of course, Polytechnic Institute of Santarém, Portugal. Some of his resource speakership and presentations include master's thesis and of life care, coping and adapting to the challenges as experienced by adult critical care nurses of Oviedo, Spain, the 8th Spanish-Portuguese Nursing Students Congress, Nurses of the World, Oviedo, Spain, Cognitive Disorders, Alzheimer's Disease, Baguio, Philippines, and of course, Through the Homes of the Gods, a report on the Philippine Central Cordillera Traverse, Baguio, Philippines. Ladies and gentlemen, to talk about the topic, virtual ICU, can it improve patient outcome? We direct our virtual spotlight to Nurse Francis Gerard Alipio.
Hello, magandang umaga po sa inyong lahat, and thank you for having me today. My name is Francis, and I will be discussing the virtual ICU, what it is, what it entails, the benefits, and the challenges that we experience with running a virtual ICU. So what exactly is the virtual ICU? So the virtual ICU can also be known as an eICU or a tele-ICU. So this is basically technology-enabled care delivered from a remote location or off-site that was developed to address the increasing complexity of patients and increasing need for intensivists. The virtual ICU is basically built on a technological infrastructure and clinical expertise to improve operational and financial performance. Now, although virtual ICUs have been in existence for about 15 to 20 years, only a small number of hospitals and intensive care units actually utilize the virtual ICU. So a study has shown that only around 11% of all intensive care units in the United States actually use telemedicine. Now, there are a number of factors why this is, but one of the main driving factors is because it costs a lot of money to actually start up a telehealth center, a virtual ICU. So what this entails is clinicians, doctors, and nurses are able to remotely surveil patients in the ICU and act as a second set of eyes for the bedside team. Now, the nurses and the intensivists, normally they are located off-site. They could be in a different town within the city, or even in a different state or country altogether. So, like, take for example where I work right now, our virtual ICU. My unit is housed off-site from our main hospital. It's in a different city from the big hospital or from the other hospitals, but also our intensivists are actually located in different parts of the globe. Some are located in Israel, in Asia, in the Middle East. So that basically shows how or where some of the team members can be located. So virtual ICUs are also most virtual ICUs actually watch over some of the smaller hospitals where there are limited resources for the bedside team. So not all hospitals have 24-hour intensivist coverage, and that's where the virtual ICU comes into play. This is especially true for my personal job right now, where we actually cover two smaller hospitals of the healthcare system that I am a part of, and these two smaller ICUs only have intensivist coverage for during the daytime or for the first 12 hours of the day. So the intensive care coverage from the virtual ICU comes in for the night shift, and that's where we mainly deliver our care. So the virtual ICUs, it's important to note that the virtual ICU RNs and the doctors are not a replacement for the bedside team. It's important to note that we are working alongside the bedside team. We are an adjunct to them. We discuss plans of care and the best plan of care for our patients. So it's a very much a collaborative effort, and what we aim to do is get the best outcomes for our patients and for the healthcare team in general. So why have a virtual ICU? So one of the reasons why the virtual ICU was set up a few years ago was basically to overcome increasing patient demands and a shortage of intensivists. Telemedicine, again, is a relatively new method of care delivery, and this has been applied to critical care. Now, for this specific one, it's applied to critical care, but there are a number of other applications for telehealth as well, which I will be running over in a bit. And again, as I mentioned, why we have an virtual ICU in my particular department, in my particular healthcare system, is because some of the smaller hospitals don't have 24-hour coverage for intensivists. Another reason is the virtual ICU RNs act as a second resource for the bedside team. Now, with the advent of the pandemic, and we've been getting a lot of newer nurses, a lot of nurses that don't have intensive care experience, and that's where we come into play. We act as a second resource, as a second set of eyes for the team. We are able to discuss how we effectively titrate medications or check on vent settings, and discuss again what's in the best interest of the patient. As I mentioned, the pandemic has brought about a number of serious challenges to healthcare systems, not only in the United States, but across the globe. And this has become a driving force for new methods in how we practice healthcare, one of which is bringing about a virtual ICU. The challenges have included increased acuity of patients, the increased number of patients that are admitted to the ICU. At the height of COVID, it was more than what certain ICUs can actually handle, or more than the number of beds they actually have. And basically the lack of staff as well, and staff being overwhelmed with the number of patients that they have to care for. Another application of the virtual ICU is streamlining communication between team members of who are caring for a patient, as well as being able to connect family members with their loved ones who are admitted to the hospital. Some hospitals have actually implemented the virtual ICU to help with infection control as well, specifically with the donning and doffing of PPEs during the pandemic. So we, again, some facilities, some healthcare facilities across the United States have utilized the virtual ICU to aid in keeping an eye and monitoring how we doff and don our PPEs because of the lack of manpower at the bedside. So the virtual ICU also enables us to shorten the time between recognizing sepsis and deterioration and giving early intervention. This is one of the drives of my current department, where we have a number of sepsis programs and deterioration programs that branch outside of the ICU. And I can discuss this in a bit and show you a bit of the workflow that we have. So as I mentioned, the sepsis milestones is one of the big driving forces of the current department that I am in, and we try to align our workflow with basically meeting milestones for like sepsis and deterioration, and trying to facilitate that in order to comply with the guidelines set about by different governing bodies, such as the CMS, which is basically similar to the PhilHealth that deals with reimbursements with hospitals in terms of certain cases that they handle. So the virtual ICU can also address issues with burnout for not just for doctors, but also for nurses, because this has become an alternative avenue for doctors and nurses who want to take a break from the bedside. It also gives them a bit of a reprieve from the stress of being physically at the bedside with patient care. So I have a number of colleagues who are actually moved from the bedside to the current role that I'm doing, and this has helped a lot with them taking a bit of a break from the bedside and acting as a second resource for the nurses, because a lot of my team members have an average of, or have a range of 10 to 20 years of ICU experience, and we sort of draw from that experience in terms of giving what's best for our team members and the patients that we care for. So the virtual ICU also enables us to have increased monitoring. We are able to trend data over the course of admission, but specifically for my workflow, we are able to trend data for at least the last 24 hours. And I can show you a bit of a widget of the screen that we see in order to have a quick view of the patient's latest vital signs or lab results. And again, this gives us an early alert, basically, for us to see if we need to intervene and change the plan of care or improve the plan of care. So just a quick view of the setup that we have. So this is one workstation of the virtual ICU that I work in. As you can see, you have about 6 monitors, but on the sides, you'll see a bit more monitors giving different data sets. So for this particular station, obviously I've had to blur the background a bit just to protect the patient privacy as well. But you will see that the monitors give you different data sets. Again, if you see on the left side, you'll see a telemetry. On the right side, you'll see a video of a patient's room, and we will be zooming in a bit more on the other monitors in a bit. And that's Sarah, one of my colleagues at work. So what do we aim to achieve in using a virtual ICU? Again, one of the main objectives is basically to have early recognition of sepsis and or deterioration. So we, in the ICU specifically, we use the Apache scoring or the SOFA score, which basically checks into organ dysfunction and is a predictor of mortality. And some studies have shown that utilizing a virtual ICU can decrease ICU mortality and either decrease the length of stay in the ICU or overall hospitalization length of stay. And again, this is basically an added resource for the bedside team. Again, I'd like to highlight this aspect because we are not in any way like a big brother to the bedside team. We are a team member, someone who works hand in hand with the clinical team, and we try to do what's best for patients, and we work together to get the best outcomes possible. So I think a lot of our work is based around mutual respect and knowing that each of us has a role to play. And when we work together, we communicate well, have mutual respect for each of our roles, we can produce some of the best care that we can have for our patients. So just going back to the early recognition of sepsis, again, this is in line with the Surviving Sepsis campaign in terms of getting the sepsis milestones in a timely manner, such as the blood cultures or a lactate, the blood cultures, getting antibiotics in within an hour, and or given fluids if needed, and getting a repeat lactate. So going specifically to the virtual ICU nurses. So the virtual ICU nurses use artificial intelligence basically to filter through the patients. Specifically for the department that I am a part of, we cover not just the ICU patients, but patients across the healthcare system, our healthcare system. So this could be anywhere between 1,300 patients to 1,700 patients who are admitted into the hospital. Now, this algorithm basically tells us the potential for a patient to be in early sepsis or early deterioration, if they're in respiratory distress or could possibly have a high shock index. So again, it uses artificial intelligence via algorithms to identify patients who may be at risk for deterioration. So once a patient filters on to us through our workstation, the virtual ICU RN reviews the chart and reviews the trends of the vital signs, the lab work, and determines from there, do we think this patient is potentially septic, or is there a potential for this patient to deteriorate in the next few minutes or the next few hours? And basing from that review, we try to get in touch with the bedside and discuss what they're seeing firsthand with the patient. Because so we try to combine the data, what we see on our end with the trends and what they see on their end firsthand. So I think the value in this is that the perspectives of the virtual ICU RNs is a bit more broader in that moment alone, because with bedside nurses, we tend to focus solely on what's happening right now during our shift. Well, in the virtual ICU, you sort of see the trend over the last 24 or 48 or 72 hours, or even from admission, and that's sort of how you determine the potential for the patient to be septic or deteriorating or in distress. So again, nurses in the virtual ICU aim to help the bedside team identify early sepsis or deterioration and meet guidelines and act as a second resource for bedside nurses. So what is our unit like? So my unit is staffed with 3 to 5 nurses, again, ranging from 10 to 20 years of ICU experience, and an intensivist. So so over the last 2 years since COVID has happened, we sort of shifted the way we have our intensivist from, we used to have our intensivist in-house within like the same room we were working in. And then because of staffing issues, they had to pull the intensivist back to the bedside, covering the bigger hospitals with 24-hour intensive care coverage. And now, because of a number of other factors, we have actually outsourced the intensive care coverage for the virtual ICU. So now we have different doctors from all over the world covering the ICUs here in my current facility. So the virtual ICU RN also we have the ability to put in orders for certain labs, specifically for the sepsis campaign and the deterioration. Two of the main labs that we put in are lactate and a CBC, because the lactate and the CBC is one of the determining factors, or at least one of the factors that would lead us to forward a patient's chart to our doctor and for them to review to potentially start a sepsis bundle. The sepsis bundle being the blood cultures, antibiotics, possibly fluids if needed, and the repeat lactate. So this is the setup for, this is a wider view of the setup that I showed earlier. If you can see my cursor over here, we have another monitor. This one is basically showing our sepsis board. So all of our patients who are being treated for sepsis or being monitored for sepsis, who have had the sepsis bundle initiated, are put up on this board to be monitored for 6 hours. And this other board is our virtual deterioration board, where we put up patients who have had rapid responses called for them, either by the virtual ICU or their primary team. So we have different milestones for this this deterioration board as well, which I will be discussing in a bit. So we have a few other boards here, basically showing data from wearable devices that show continuous vital signs. And this one is a board for the emergency room patients that are going to be admitted. So again, we filter all of the patients across the system, which is why, the patients could be potentially from anywhere from 1,100 to 1,700 patients. So just going specifically back to the two programs that are one of the main programs of my department. So the sepsis campaign looks into, again, early signs of sepsis for patients. This one is, again, mainly driven by your SIRS criteria. So it's a white count of more than 12 or less than 4, heart rate more than 90, respiratory rate of more than 20, temperature above 38, and other factors such as comorbidities, patient's age, patient's gender. And again, for both of these, for sepsis and deterioration, we get them through a certain list, which I will be showing in a bit. The other one is deterioration, virtual deterioration. This is a relatively new project of my department, where the virtual ICU is able to call rapid responses for the bedside nurses on the floor. So we're able to give advice and give basic nursing interventions until the primary team arrives or is able to be contacted. So we follow these rapid responses for about 6 hours, monitoring them for the milestones that we have set as well. So the main goal for the virtual deterioration project is basically to again, early recognition, but mainly to have early intervention as well. So I believe one data point that they looked at was how quickly is a doctor or a provider able to respond at the bedside to a rapid response. And they showed, I believe the data showed, at least the local data showed, that there was a bit of a delay with how the providers responded to rapid responses at the bedside. So they came up with this project to be able to involve us and possibly bridge the gap or shorten the gap in terms of getting interventions in place and either proceeding to higher level of care or keeping the patient on the current floor. So just a quick view of how we monitor patients in the ICU. So we have, so this picture here shows us the different severity scores of a patient. So it shows the trend of the severity scores. Again, the severity scoring is based largely off of our Apache scores and SOFA scores as well. So we are able to trend the data over here. And on this right picture, you will see different data points where you can see a patient's vent settings, specifically the FiO2, non-invasive blood pressure, possibly an A-line blood pressure if they have one, pulses as well. So you can see trend lines if, is it improving or is it getting worse? And you can also see the shock index and the SOFA score. So these two monitoring pictures are mainly for the ICU. This picture is for all of the patients. This is one of the widgets on one of the monitors for our workstations. So once you open up a patient, this is what you will see on the side. So again, it goes to show how much data you can actually analyze and see once you click into a patient in the virtual ICU. So you'll see on the left side, you'll see the 24-hour trend of vital signs. And you'll also see the infusions that they have when the patient was admitted, their sepsis or deterioration scores, what are their oxygen settings, what are their I's and O's over the last 4 to 5 days, their current medications, their invasive lines, and their infectious diseases history. Have they had blood cultures done in the last 24 hours or 48 hours? Have they had a lactate drawn? Are they on any antibiotics at the moment? So again, this to my point earlier, where we are able to access relatively large amounts of data in a very short period of time compared to what one would see at the bedside if you were handling 5 to 6 patients on the med-surg floor, or even more sometimes. And this 2 pictures. So this, if you remember what I said about how patients on the med-surg floor filter to us, this is our med-surg list. So all of the patients who are admitted on the floor, meaning outside of the ICU, are filtered onto this list. So depending on what they're alerting for, so for example, this top one is alerting for their deterioration index, showing a score of 57. This second one is scoring because of a sepsis score, which is a 5. And the third and fourth one are deterioration in sepsis as well. So we have other scoring systems as well, like the shock index and the respiratory distress index. So again, this is based off of artificial intelligence that calculates a number of factors such as vital signs, your age, gender, laboratory work, and comorbidities. And this bottom one is our sepsis board, which shows your different milestones. So for our workflow in the virtual ICU, we base off of for sepsis at least, we base off of the initial lactate. If the lactate results at an elevated level, which is more than 2, we forward the chart to the medical doctor and they review the chart. If they are concerned for sepsis, they get in touch with the bedside team to discuss ordering the sepsis bundle. Now, once they order the sepsis bundle, which are the blood cultures, antibiotics, repeat lactate, fluids if needed, we put them up on this specific board. So again, the ones I mentioned are all of your milestones, and we keep them up on this board for 6 hours for monitoring for hemodynamic instability. So this pertains specifically to the virtual deterioration project that we have. Again, this has only been going for about 2 to 3 months. This was brought about because of the increased unplanned ICU admissions, basically emergent intubations on the floor, emergent ICU transfers, which when they looked at the data, they could have seen earlier and could have prevented an emergent transfer or an emergent procedure. So again, because of the large data that we receive, we are able to assess patients' trends a bit more detail. So just showing you the inclusion criteria for us being able to call a rapid response. So it's basically a 20% instability from a patient's baseline. Now, of course, this is not set in stone. This will all be based on our review and our discussion with the bedside team, because these changes could be brought about a number of different factors, such as the patient was ambulating to the bathroom or the patient was doing physical therapy, and that's why we try to make it a point to be able to discuss with the primary team what the patient looks like, and discuss if they have any concerns about the patient possibly deteriorating. This bottom picture shows the milestones of our virtual deterioration project. So this rapid response camera at bedside, we've been able to set up different cameras on the different floors of all of the or of some of the hospitals in the healthcare system. And so if they are part of this project, we request the bedside team to bring in the rapid response camera just so we can visualize the patient as well. So we have certain milestones, again, getting the bedside provider or medical doctor to be present, or at least be able to be contacted within 30 minutes and have interventions in place. So these are both 30 minutes. For example, if they are not able to get in touch with the doctor within 30 minutes, that's where the virtual ICU comes in, and they loop us in and we loop in the doctor who is located in the virtual ICU. And another milestone is being able to review the level of care. We want the level of care be determined within an hour to an hour and a half, and be able to put in post-rapid response vital signs check, because different units have different protocols in terms of how frequent they can monitor their vital signs for their patients. So obviously, if a patient is post-rapid response, you want their vital signs to be monitored a bit frequently after. And sometimes I feel like that should go without saying, but this is not always implemented. And this is one of the reasons why we have this deterioration project. So this is just the sepsis and deterioration scores. So these two pictures just basically show what are the factors that go into the scores that the patients have for us. So if you remember, the patient earlier had, say, a score of 57, or for this specific example, this one has a score of 68. So we look at these factors, and this is what comprises the 68 score. And we look at this respiratory rate of 30, patient is 70 years old, the patient is on supplemental oxygen. And so we review all of this data. We determine, is this a worsening trend, or is this a temporary trend? And then again, we try to get in touch with the bedside. So other possible projects of the virtual ICU or the virtual health center is remote patient monitoring. And this was brought about because of COVID. So remote patient monitoring for my specific facility was brought about because of COVID, where there were a lot of patients in the ER, but not all of them warranted admission. But they were, however, high risk of deteriorating because of a number of risk factors such as age, BMI, comorbidities. And these were the specific patients that were put into this program. They basically have a wearable device on their wrist and a probe that monitors their heart rate, their respiratory rate, and their pulse oximeter and their pulse ox. And this data is transmitted to their phone, which is then transmitted over to the virtual ICU. And this is something that we also watch over. And if we determine that the patient is deteriorating, we either get them back to the hospital or send an ambulance to pick them up. And another program is the hospital at home. This is an up-and-coming program across the US, I believe, where we basically bring the care to a patient's home. So now as hospitals reconsider how and where they deliver care to patients, many are seeing the hospital at home model as a promising approach to improve value. Hospital at home enables some patients who need acute level care to receive care in their homes rather than in a hospital. So basically, this care delivery model has been shown to reduce costs, improve outcomes, and enhance the patient experience because they're in a familiar environment, they have their loved ones around, and again, the care is brought into their home. So this, like seeing the virtual ICU, seeing the setup, when I first started the job, I felt like, wow, this awesome. You have all of this technology, you have all of this data to your disposal, but it did come with a lot of challenges, and it still comes with a lot of challenges. One of which is, the constant changes, being technology driven, being a novel aspect in delivering care. There is constant change, and you do deal a lot with change fatigue and constant change management. So it's, I think, explaining to team members why these changes are happening, or the value in changing the way things are done is very important for team members to be able to transition into this change smoothly, and have better acceptance of the changes that are implemented. Another challenge is staff buy-in. Now, when I say staff buy-in, it's more the bedside staff buy-in, because again, it's a relatively new thing, where a lot of people think we're playing Big Brother or trying to micromanage the bedside. But in reality, we have been a really good resource for a lot of the newer nurses, especially with COVID happening, where a lot of the nurses thought it's normal to have a patient sitting in the low 80s or high 70s, and for a lot of the newer nurses, it was like, oh yeah, it's COVID, we don't need to do anything else because they'll pick up in a bit. But the next thing you know, it's like been an hour already and the patient is still sitting 75%. Basically it's staff buy-in for the bedside team. And this takes a lot of education and a lot of, again, mutual respect, and knowing that each of us has a role to play in the patient's care and in the healthcare team. And the obviously finances is a big challenge for most healthcare organizations. Again, it takes a lot of money to just get a virtual ICU up and running. So I think that's one of the biggest things that makes organizations hesitate to set up their own virtual ICU. But once it's set up, I think it's a valuable resource, and it's a resource that will keep on growing in the next few years, given that telemedicine has really expanded over the last 5 years, and more so over the last 2 years with COVID happening. And I believe that is the end of our discussion. So in conclusion, the virtual ICU is designed to supplement the increasing need for critical care and address clinician burnout. and it has also been shown to decrease ICU mortality and length of stay in some studies. The virtual ICU is not in any way a replacement for the bedside team, but an added resource and part of the overall healthcare team, again, to be able to produce better outcomes for our patients. Thank you very much for your time, and I'm happy to answer any questions if there are any. Oh, and hello, Ma'am Abby. Ma'am Abby is the OG from our time working in UST, Faculty of Medicine and Surgery. Hi, Ma'am Abs.
All right. There you have it, ladies and gentlemen. It's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am sure you've got lots of questions to our speaker. To answer your questions, I would like to bring you back our speaker, Mr. Francis Gerard Alipio, together with our moderator, Mr. Alphon Killier Daga, to the virtual stage, gentlemen.
Oh, wow. So once again, ladies and gentlemen, fellow nurses and frontliners, talking about to everyone the topic, virtual ICU, can it improve a patient outcome? Let's all together give our warmest virtual round of applause to Nurse Francis Gerard Alipio. Hi, sir. Good morning.
Hi, good morning. Maraming salamat po.
How are you doing? What time is it there?
It is now 7:49 in the evening right now.
Wow.
Colorado, yeah.
Thank you very much for joining us. How can we call you, sir? Can we call you Francis?
Oh, yeah. Just stick with Francis. Yung Gerard kasi medyo pang-formal na setting. But yeah, I just usually go by Francis.
All right. Thank you, Sir Francis. So, Sir Francis, I'm just very curious. How did you become a virtual ICU nurse? I mean, is there a specific training for that? Did you have to be a bedside ICU nurse first before you transitioned to becoming a virtual ICU nurse? How is it?
Yeah. So most virtual ICU nurse jobs require a number of years for to be an ICU nurse, like a bedside ICU nurse. In my case, when I first applied, they required about 8 years, I think, of bedside ICU nursing experience. So this will differ from one facility to another, but that was specific for when I applied for this job. Now, the reason why I applied for this job was, a number of factors came into play. I came from a very high acuity ICU. My first job in the United States was a very high acuity ICU in a relatively large city. So I must admit, part of it was because I was burned out as well at the bedside, and I think one of the opportunities that this gives me, at least in this role, is being an educator and a resource for a lot of the newer nurses. So, and I do have a passion for teaching. I have a passion for, helping newer nurses as well learn the ropes, because I started off on the med-surg floor and I had very good preceptors. I had very good seniors who welcomed me into their floor and showed me the ropes. And I want to impart that at a larger scale, so to speak, because while I was a preceptor at the bedside, you'd get one new nurse every 1 or 2 months. But in this role, the scope of your being able to educate nurses is a bit wider, in the sense that, again, in my current role, we basically cover the entire healthcare system that I'm a part of, and this is about 8 to 9 hospitals, I think, across the state of Colorado. So you have a far-reaching impact in terms of being able to educate and help other nurses.
Oh, wow. So did I understand it right? You are a virtual nurse, but you are serving 8 to 9 hospitals right now.
Yes. So that's how the virtual ICU, for the most part at least, works. I think I did forget to mention that, or I guess I sort of explained it in my presentation, but my virtual ICU, the virtual ICU that I'm a part of, is sort of a hybrid virtual ICU in the sense that we don't only monitor the patients in the ICU, but to a certain degree, we also keep an eye on floor patients. Basically, anyone who's admitted gets filtered on to us, again via the med search list that I showed, and yeah, it's through that we get in touch with the bedside nurses and try to communicate with them.
Well, Sir Francis, according to Amiel Reyes, this is really amazing because what you're doing is amazing. That's really something new, perhaps, to most nurses. And I think that tickled the interest of our participants. Lorene May Dariano is asking, what are the skill sets or competencies required for virtual ICU nursing? Again, what are the skill sets or competencies required in order for one to become a virtual ICU nurse? Your thoughts, Sir Francis?
I think personally, I think experience is the biggest thing. I think the things that we learn in a classroom or in a lecture is very different from what you actually see at the clinical setting or at the bedside. So I think having a solid number of years of experience at the bedside gives you that I guess confidence and knowledge and skill set behind you to be able to back what you discuss with the bedside as well. But as far as formal competencies and training, I would say basic ICU skills such as titrating your vasopressors, vent settings, being able to manage vent settings, or at least be knowledgeable about vent settings. If you are in a specialization such as a cardiovascular ICU, familiarity with IABPs and ventricular assist devices as well, I think does come in handy depending on the virtual ICU that you're a part of, because sometimes you will be covering ICUs that do have those that capacity, as well as basic CRRT skills and hemodynamics, obviously.
So basically, Sir Francis, it's like being a critical care nurse transitioning to the virtual platform.
Yes, it is very much a critical care nurse role. We are identified as ICU nurses still, and again, we're a very diverse group of rather experienced nurses, and the beauty of this role is, again, you're able to educate a lot of nurses, but also you're able to educate yourselves as well in terms of, I won't ever claim that I know everything about the ICU patients. I won't ever claim that I know everything about ICU care, but I do have resources right next to me. Like I have someone who has 15 years or X number of years of experience, who's experienced a number of other things that I have not experienced. So I'm able to discuss these things with them. So it's kind of like it is very much a collaborative effort, and there's a lot of brainstorming and a lot of discussing in terms of how you want to proceed with patient care.
So to our dear nurses who are planning to become a virtual ICU nurse, you heard the answer coming from our speaker, Sir Francis Gerard Alipio. We have another question, Sir Francis, that is raised. This question is from Dr. Larry King. Good morning, Dr. King. So he is asking, which is more taxing or stressful, working as bedside ICU nurse or a virtual ICU nurse? Which is more fulfilling? Again, which is more taxing or stressful, working as a bedside ICU nurse or a virtual ICU nurse? And at the same time, which is more fulfilling? Your answer, Sir Francis?
Before that, hi, Dr. King. Thank you for having me. Thank you for having us, our group from UST. I think that's a very good question. In terms of fulfillment, I do find both roles fulfilling. I don't think I can quantify which one is more fulfilling over the other. But in terms of stress, I would say I'd still say the stress of the bedside does come with a lot of challenges because it's more physical and mental stress. I have to admit, a lot of the nurses who sort of job share with us. When I say job share, they still work at the bedside, but also work in the virtual ICU. the stress at the bedside is definitely different. I spent close to 14, 15 years doing bedside nursing. And it's definitely very stressful on your body, physically and mentally. With the virtual ICU, the stress is more mental, because there's, again, very large numbers of data coming in, and you have to analyze this in a rather quick manner. So, but also the adjustment period from being a bedside nurse, from being in the front lines and being where the action is, and then coming to a place where you're seated behind a desk and trying to understand all of these workflows. That part is very stressful, because it's very different from what you're used to. Like, you're very used to, caring for a patient, one or two patients. But with this one, there's a very different kind of pressure that comes along with it, because, people expect you to, basically know everything, which, admittedly, obviously we don't know everything. But there is that pressure that comes with this role. But also the stress of, again, change management. Over the last 2 years, like, these projects that they keep on adding on to our work is rather stressful. And, you do come to a point where you start thinking, how much can your mind actually take in, and how much can your mind actually process in a given day? Because you have your sepsis project, you have your deterioration project, you have your ICU that you have to watch over. And that part does get stressful. And so, to answer the question, it is two very different worlds, two very different stressors. So, but yeah, both are very enjoyable. Both are very fulfilling, I think.
All right. Thank you very much, Sir Francis. I guess we can entertain our final questions. We actually have a lot of questions coming in, but for the interest of time, we shall have our final question for Sir Francis. So, Sir Francis, Julie Christie Vesperas is asking, how many hours does a virtual ICU nurse go on duty? And do you have endorsements when shifting teams? Your thoughts, Sir Francis?
So yes, we do have endorsements. We sign out our patients from the previous shift, specifically our ICU patients. We sign them off to the incoming nurse. We endorse them to the incoming nurses. We endorse the sepsis cases as well as the deterioration cases. We endorse the ICU patients for obvious reasons, for continuity of care, for the sepsis and deterioration, also for continuity of care, because we do have milestones that we want to achieve. Again, we want to achieve these milestones in a specific time frame, and that's why we hand over and endorse our patients. As far as nurses work 12 hours, so it's 3 days in a week. That's your full-time work, 36 hours basically. MDs cover the virtual ICU mainly at night. So it's like a 12-hour shift as well for them. But the thing with doctors who cover the ICU, sometimes they cover their own ICUs, like their actual ICUs in person during the day. So it's hard to answer that question, given that I'm not the one doing that, because I'm not the doctor. But I believe they do cover like more or less 24 hours. It's interesting because, as I mentioned in the presentation, we've gone outsourcing. We've outsourced our intensivists now. So a lot of them are based abroad, not in the United States. So it kind of works out where it's nighttime over here, and our intensivist over in Asia is a daytime. It's daytime on their end, and by the time that it's daytime over here, it's nighttime over there. So they basically cover their own ICUs over there as well. And we do have intensive care doctors from the Philippines who do this with virtual ICUs here in the States. Yeah.
All right. Thank you very much. You heard it straight from the man. Ladies and gentlemen, fellow nurses and frontliners, once again, let's all together give our warmest virtual round of applause to our virtual ICU nurse, Mr. Francis Gerard Alipio. Thank you very much, sir.
Thank you. Thank you again, everyone, for having me. If you do have any further questions, I believe our emails are in the brochures. Do send them over. I will be happy to answer them. And again, Dr. King, to the reps of Delex Pharma, thank you very much for having me. Hi, Michael, Annie, Abby, and everyone else. Thank you very much.
Thank you so much, sir. Alrighty, so at this point, we'd also love to hear something coming from our world-class Filipino nurses who are joining us today. We have 2,700 strong world-class Filipino nurses, 2,700 nurses whose hearts are ready for pumping, and of course, 2,700 nurses whose minds are in unison. We'd like to hear something from everyone. I will be grouping you into our main island groups, Luzon, Visayas, Mindanao, and of course, our nurses who are situated abroad. As I announce your respective island group, I would want everyone to go ahead and type in the chat box, where are you located right now? All right. Padamihan ng entries to at palakasan ng energy. All right. Without much ado, let's go ahead and start this off. We'd like to hear something coming from our nurses who are from Luzon. Mag-ingay from Luzon. Where are you located right now? From Luzon, we have from Vigan, Benguet, Zambales. We have from Rizal. Wow. From Luzon, mag-ingay ang ating mga nurses from Luzon. Michelle Talosig is from Bulacan. Good morning. Adrian Miliana is from Sorsogon. Gerald Manimbo is from Cavite. Magandang umaga. We'd like to hear something coming from our nurses from Luzon. Come on. Oy, Merry Chris, Luzon pa lang tayo. Ayan. We have Melania from Calamba. Good morning. Who else? Jose Andrelin de la Cruz from Quezon City. Good morning. We also have someone from Silang, Cavite. Magandang umaga. All right. This time, hindi magpapahuli sa energy. Our participants coming from Visayas, coming from the Visayas. Yes, I am proudly from Visayas. I am from Eastern Visayas. Maupay na aga ha aton nga tanan. Shout out, of course, to our nurses from the Eastern Visayas Medical Center. I believe that our EVMC IPC is still tuning with us today. Good morning from Visayas. Come on, where are our nurses from Visayas? We have someone from Andrew Sumpay from Tacloban. Maupay na aga. All right, where are our nurses from Visayas? Come on. We have someone from Calibo, Aklan. Good morning. Oh, wow. Mary Trinity Aniversario is from Iloilo. Maria Montserrat Nolasco is from Capiz. Good morning. All right, come on. Nasaan pa ang ating nurses from Visayas? Army Marie Lagado. Hi, Ma'am Arms. Good morning from Tacloban. All right, let's go down south and proceed to hear from our nurses who are located in Mindanao, Zamboanga City. Sadrina, good morning from Davao City. All right, Zamboanga City, Farah Lopez. We have someone from Barm, Maguindanao. Good morning. From Misamis Oriental, Albimi. Wow. King City of South, Davao. Yes, Ruel is located there. Who else? Located, Christian Joy Salas from Davao City. Good morning. All right, so after having Luzon, Visayas, and Mindanao, we'd also want to hear something coming from our participants who are located abroad. Where are you located right now? Nurses from abroad. I saw someone who is in KSA right now. Roland Santos is from Los Angeles, California. We have Ma'am Virginia from Canada. Good morning. We have someone from Riyadh. Wow, thank you for joining us. Irene is from Manila. Yes. Mylene Pexon, good morning. Okay, who else are located abroad? Come on. Anna Victoria is from Oman. Wow, thank you for joining us. We have someone from the US, from UK, KSA, Fredez Winda. Good morning from KSA. Naku, talagang nakakatuwang maisip no na marami tayong nurses who are also located abroad and joining this Delex-ICU forum. We have someone from UAE as well. Good morning. Oh, wow. Thank you, everyone. Oh, Los Angeles City, Pampanga. Oh, itinayo talaga ang bandila ni Jefferson. Ace Marco is from California. Thank you, everyone. All right. So thank you, everyone, for participating in that short activity that we had. We are very glad to welcome all our nurses coming from Luzon, Visayas, Mindanao, and other countries. Thank you very much for joining our Delex Pharma ICU Forum as we all together celebrate our world-class Filipino nurses. By the way, I'd also want to give this special shout out as well to Governor Clement John Navarrete. Hi, Gov CJ, good morning, and to our other PNA governors. After getting to hear the talk coming from Sir Francis Gerard Alipio, this time let's go ahead and proceed with this batch of another world-class Filipino nurses. Wow, all right. So we got to hear the talk coming from Nurse Francis Gerard Alipio about the topic virtual ICU. Can it improve a patient outcome? At this point, after getting to hear his talk, do you think that virtual ICU indeed can improve patient outcome? Well, I think that we were already able to derive the answer coming from his talk. By the way, at this point, we'd like to inform everyone that for our succeeding topics, we'll be joined by a certified registered nurse anesthetist, a nurse practitioner, a clinical nurse specialist, and of course, a nurse leads. Now, all four of them will be able to discuss one common topic entitled The Many Caps of a Nurse, How to Advance Nursing Profession Practice in the United States. Are you ready? Without much ado, let's go ahead and proceed with our second speaker for today. Our second speaker attained his Bachelor of Science in Medical Technology at the University of Santo Tomas, and at the same time Bachelor of Science in Nursing at Dr. Lanting College. His MS in Nurse Anesthesia at the University of Southern California, Los Angeles. DNP Nursing, Duke University, Durham, North Carolina. Director of Simulation Program, University of Southern California, Program of Nurse Anesthesia, and of course, Faculty Nurse Anesthetist 2, Anesthesia, LAC, plus USC Medical Center, California. His affiliations include Chair, SEE Item Writing Committee, National Board of Certification and Recertification for Nurse Anesthetists, Item Writer and Mentor. To new item writers, SEE Item Writing Committee, National Board of Certification and Recertification for Nurse Anesthetists, past President of the Philippine Nurses Association of Southern California, and of course, an active member of the American Association of Nurse Anesthetists. At this point, we direct the spotlight to Dr. Regalado A. Valerio for his topic entitled Certified Registered Nurse Anesthetist.
Good morning to everyone in the Philippines and good evening here in Los Angeles, California. And to all the participants and all the attendees around the world, kamusta po kayong lahat? I am a registered nurse here in the US, and I'm very sure that many of you who are dreaming to be working abroad have different motivations. First is probably the monetary reward. But I always say that money should not be your primary motivation in working abroad as a nurse because you will not last long with our profession. The second motivation probably is the practice. The practice here in the United States, specifically based on my experience, is very conducive to raise a family. The practice is very safe. It is efficient and effective. It is evidence-based. It is culturally sensitive and very diverse. So overall, the practice is really great. And I think the number one for me, the motivation is actually the opportunities. Nursing here in the United States can be highly generalized. You can be a bedside nurse for a long time, or it can be highly specialized. There's a lot of routes in order for you to advance as a nurse in the United States. And that is the focus of our topic for today. The many caps of nurses here in the United States. How to advance. So for the first leg of our discussion, I will be discussing myself. What am I? I am a certified registered nurse anesthetist. Other people call me certified registered nurse anesthesiologist. I'm very sure in the Philippines, the practice of anesthesia is solely given to our MD colleagues, which is our anesthesiologist. However, here in the United States, believe it or not, an advanced practice nurse like myself can administer anesthesia in all sorts of surgical procedure, may it be general anesthesia, regional anesthesia, local anesthetic, or monitored anesthesia care. But did you know that nurse anesthesia has its roots since 1800? Nurse anesthetist is one of the first healthcare providers dedicated to the specialty of anesthesia. We have our roots in the 1800s when the nurses first gave anesthesia to the wounded soldiers in the battlefields of Civil War. Today, certified registered nurse anesthetists are advanced practice registered nurses with graduate level education who enjoy a high degree of autonomy and professional respect. We provide anesthetics to patients in every practice setting and for every type of surgical procedure. We are also the sole anesthesia providers in nearly all rural hospitals here in the United States and the main provider of anesthesia to the men and women serving the U.S. Armed Forces. So my topic for today will evolve in 5 things. First and foremost, I will be discussing the educational preparation. How do you become a CRNA here in the United States? The second is, how do you practice the CRNA profession in the United States? What's the certification requirement? The third will be the job description. What do I do as a nurse anesthetist? And then I will be describing the setting of my work. And the last but not certainly the least is the professional perks that I receive as a certified registered nurse anesthetist. So flash on your screen is actually the whole curriculum for the USC Program of Nurse Anesthesia, Keck School of Medicine. It's 2 pages. It's actually a 3-year program. So first and foremost, before you apply to a CRNA program, you have to have a critical care experience. So you can be an ICU nurse, an ER nurse, a pediatric ICU nurse, or a neonatology nurse in the ICU. And then you apply to the program. During my time when I started the program way back in 2011, that was more than 10 years ago, the program is only a master's prepared program. So after my program for 2 years, I got a degree in Master's of Science in Nurse Anesthesia Practice. But since the recommendation of the Institute of Medicine to advance all the allied nursing professions, especially nursing, we have a mandate to transition all the programs in the United States into a doctorally prepared nurse anesthesia program. In fact, the one that I work for right now, my own alma mater, the USC Program of Nurse Anesthesia, we transitioned in 2017, and we have our first graduates last 2020. So our program now is a doctorally prepared nurse anesthesia program. What is the difference between a master's and a doctorally prepared nurse anesthesia program? Can I still practice nurse anesthesia if I have a master's degree? Yes. In fact, I don't really have to go back to school to finish my doctoral study to practice nurse anesthesia here in the United States. However, since I'm a faculty, I'm teaching students who are doctorally prepared nurse anesthetists. It is my own initiative to go back to school and finish my doctoral study at Duke University in 2017. And since then, I was immediately hired by the program of nurse anesthesia. And right now, I am currently the faculty. What's the difference? First and foremost, in a master's program for nurse anesthesia, you learn the art and science of anesthesia. You learn the pathophysiology of diseases. You learn advanced pharmacology. You learn all the how to intubate, how to be an airway expert. In the doctorally prepared nurse anesthesia program, it's like a step up. It's like looking at a problem and you are stepping back and looking at the global picture. It is not like merely intubating a patient, having a safe anesthetic, going to the procedure. No. In the doctorally prepared nurse anesthesia, we prepared students to become leaders in the operating room. We solve problems. We make sure that we analyze system processes. We champion quality improvement projects. We venture into research, and we do a lot of professional advocacies. But both masters and doctorally prepared nurse anesthesia can practice anesthesia here in the United States. As I've said, I handle 2 courses for the program. I am currently their simulation director, and I handle 2 simulation courses for the program of nurse anesthesia. First, I handle the first year students, like an introductory course for simulation. And before they graduate, I handle again for the simulation. Just what I do so that you can easily understand it. I have a 3-minute video that you can watch so that you can understand what I do as a simulation director. Here it is.
Hi, right now you are at LAC-USC Department of Anesthesiology Simulation Center. My name is Dr. Regalado A. Valerio Jr. You can call me Reggie, and I am your director for the simulation program of the USC Program of Nurse Anesthesia Tech School of Medicine. Your anesthesia simulation team is comprised of Mr. Seth Cambao, a simulation faculty, and a faculty nurse anesthetist here at LAC-USC Medical Center. Is Jackie Moore, who is an anesthesia technologist and simulation coordinator at LAC-USC Medical Center. And yours truly. As your simulation team and facilitators, we will be developing scenarios that are appropriate for your learnings, administer this scenario in a supportive and safe environment, and we will be facilitating debriefing to complete an effective learning experience. The USC Program of Nurse Anesthesia has 2 simulation courses. The first is ANST 631, usually happening on your first year fall semester. And the next one is a more advanced ANST 633, usually on your summer senior year. The goal of the program of nurse anesthesia is to produce competent nurse anesthetists who will be leaders in the operating room that can work within the current multifaceted, complex healthcare system. And the advantage of simulation is that it allows learning to take place in a safe and controlled environment where there is no threat for patient harm. In simulation, we give highest regard to the concept of psychological safety. Psychological safety is a shared belief held by all members of the team that the team is safe for interpersonal risk-taking. And as your facilitators, we encourage each participant in simulation to be just vulnerable and be open to learning. Don't be scared to commit mistakes because in simulation, you will be committing mistakes. And we encourage that because from that mistake, learning will happen. Remember, what happens in simulation stays in simulation. Your simulation session starts with a pre-brief. This is the information session prior to the simulation proper. This is where we establish psychological safety and set the tone and to focus learners on the main objective of simulation. The next one is the actual simulation proper, the dreaded, the nerve-wracking, where the crazy things happen. In simulation proper, this is where we practice the concepts of team training, where we will practice good leadership skills, peer observation, flexibility, group membership, balance, trust, and effective and good communication. And the last but not the least is the heart of simulation, where learning experience really happen. This is what we call the debriefing. It is the period of the time following an experiential learning activity during which learners or team reflect, review, and discuss the activity with the goal of improving individual and team clinical skills and judgment. Again, welcome to the simulation program of the USC Program of Nurse Anesthesia, Tech School of Medicine. Hi.
So after graduating the nurse anesthesia program, now it's a 3-year program compared to 2 years before as a master's prepared program, you will be taking your board exam. This is like the PRC in the Philippines, the Professional Regulation Commission. But the nurse anesthesia is provided, the certification is provided or facilitated by the National Board of Certification and Recertification of Nurse Anesthetists, or the NBCRNA. This is a not-for-profit corporation dedicated to promoting patient safety by enhancing provider quality in the field of nurse anesthesia. Right now, there are nearly 60,000 CRNAs in the country, in the United States, working in every healthcare settings, maybe it private hospital, public hospital, both rural and urban settings in every state in US. So I will be describing my workplace. Currently, we are 42 nurse anesthetists at LA County USC Medical Center. So when you say LA County USC Medical Center, it is one of the biggest public hospital in the United States. It's like the PGH in the Philippines. And we CRNAs can be considered as most cost-effective and advanced practice practitioner in anesthesia. Our work productivity that I will discuss. Number one, we provide anesthesia service to more than 50% of the entire LA County OR caseload. Remember also that we are serving the underserved population in LA County area. We have 26 main operating rooms, including trauma cases. And we also cover nurse anesthetists cover also preoperative evaluation centers and clearance for pre-op. We're clearing patients for surgery. And also we are doing almost 100% of all the cases or out of the OR caseload in the county system. It is like the offsite cases, the cardiac catheterization, the neuroendovascular surgery, even the liver procedures such as TIPS, we cover that. The GI procedures such as endoscopies, colonoscopies, and ERCPs, bronchoscopies, GYN oncology or brachytherapy, MRI, CT scan, we cover those kinds of procedures. So you can see that LAC CRNAs, we call it LAC, it's like LA County CRNAs, are safe, cost-effective, and we provide quality care. We are highly valued in the county system because we deliver the same safe, high-quality anesthesia care as other anesthesia professionals in the country. In fact, Medicare and medical reimbursements have the same amount of fees for an anesthesia service, whether it is provided by a CRNA or an anesthesiologist. The Joint Commission also, or the JCO, recognized CRNA as a licensed independent practitioner. Also, we increase service production and decrease surgical backlog, especially during COVID. We provide care in many healthcare settings. As I've said, I work for LA County. I work 12-hour shifts. 312, so I have 4 days off, so I can still manage to do private practice. So I also work in private practice setting, not only in the public hospital. And lastly, the California legislature allows CRNAs to administer anesthesia service without the supervision of the physician. And this is the picture of my team. I'm very proud that I'm included to this, the CRNAs of LAC USC Medical Center. And I would like to tell you the perks. First and foremost, as a CRNA, I do what I love. I'm always fascinated with anesthesia, putting patient to sleep, and being there with the patient, staying with the patient all throughout the most vulnerable part of their lives, which is a surgical procedure. Number two perk is actually the salary. As I've said, it's not the number one. My passion is really anesthesia. The second probably is the monetary reward. The salary of a nurse anesthetist might be one of the highest among the advanced practice nurses in the country. We also have we have the opportunity to teach. I teach my students. I love to teach. We have also flexible work hours. I mentioned that I can work 312 hours, but I also work private practice. Meaning I work for surgery centers for cosmetic procedures, ENT procedures, orthopedic procedures, pain procedures. So it seems like I tell my wife that I'm going to go to a shopping mall or a Walmart, but I'm really working. And then after 2 hours, I'm done with the breast augmentation and I can enjoy the family afterwards. So the flexible work hours is really great with CRNA. And probably the many work opportunities. You can be a nurse leader, you can do professional advocacy, you can do research, you can do anesthesia in offsite solely in the main operating room, you can do public practice, public hospital, you can do private practice, every single thing you can try as a nurse anesthetist. And finally, my final slide. Right now, I do have a family that I enjoy. It's number one for sure. But I am an educator and a simulation specialist. I am also very active with the community. I'm serving the Philippine Nurses Association of Southern California. In fact, my fellow panelists today are all nurse leaders of the Philippine Nurses Association of Southern California, to include our current parliamentarian, also a previous president, our Dr. Cuenca. Ms. Velma Yap is our current vice president, and Mr. Roland Santos is our current president right now. I also had a chance to publish my work. I mentor students, doctorally prepared students, to publish their work as well. And lastly, I volunteer for the NBCRNA. I write exam questions like in the PRC for nurse anesthesia, and these are the things that I love to do. Lastly, as a parting word, I always say this, many people will hear me, that I am a proud nurse here in the United States, but I am more proud to be a certified registered nurse anesthetist, but I am most proud to be a Filipino nurse anesthetist. Thank you very much for listening.
Oh wow, so we just got to hear the experiences coming from Dr. Regalado Valerio about the experiences of a certified registered nurse anesthetist. I'm pretty sure, Dr. Valerio, that you were able to tickle the interest of our fellow Filipino nurses who are currently joining us. At this point, we still have 5,000 strong participants, and let's go ahead and get to know our our next speaker for this session. Our next speaker attained her Bachelor of Science in Nursing at the Chinese General Hospital College of Nursing here in the Philippines, and at the same time her Master of Science in Nursing at the UCLA School of Nursing, LA. Her Doctor of Nursing at the University of California, LA. Her professional experiences include bariatric or weight and nutrition nurse practitioner, Pomona Valley Hospital Medical Center, ambulatory and urgent care, NP, Chino Hills Urgent Care Ambulatory Medicine, and of course, urgent care internal medicine, Chaparral Medical Group. Some of her certifications include Critical Care Certified Registered Nurse, Drug Enforcement Administration, National Provider Identifier, American Nurses Credentialing Center National Board Certification, Geriatric Nurse Practitioner, Advanced Cardiac Life Support Certification for Adult, and of course, Basic Cardiac Life Support. Without further ado, let's go ahead and listen to the experiences, this time coming from a nurse practitioner. We have Dr. Velma Yap.
Hello. Good afternoon. Well, good morning to the Filipino nurses and good evening to the nurses in the United States. So if you can hear me fairly well, that's good. And if you can't, then just call my attention. So I am Velma Yap. I am a board certified geriatric nurse practitioner. And before I move on with my presentation, I would like to thank Rian or Ian for inviting me for this presentation. This is really a great opportunity for me to share who I am and what I do. So I am a nurse practitioner. And what is a nurse practitioner? So in hindsight, a nurse practitioner is one of the advanced practice nurses, just like Dr. Regalado. The four categories of advanced practice nurses in the United States are the nurse anesthetist, we have the nurse practitioners, clinical nurse specialists, and also nurse midwives. And what is a nurse practitioner? So a nurse practitioner is an advanced practice nurse, a registered nurse with an advanced education, preferably a master's degree, and now we have the doctorate degree, just like what I have, with skills, knowledge, and advancement in education to practice as a nurse practitioner. So let me tell you how the nurse practitioner role evolved. The historical background starts from in 1960 by Dr. Loretta Ford, who is a nurse practitioner, and Dr. Henry Silva. I'm going to share you my slide briefly right now. A very short slide. I only have 4 slides, but I'm going to be talking more. Okay, so this evolved in 1960, the role of nurse practitioners. It started in the state of Colorado out of the need to increase patients' access to pediatric care in the underserved areas. So in 1974, the American Nurses Association created the Council of Primary Care Nurse Practitioners. This is a movement that helped solidify the role of nurse practitioners in the United States healthcare system. So the USA was the first country to introduce nurse practitioners in 1965, followed by Canada in 1967. I'm not quite sure if there's already other countries that have started nurse practitioner programs, and I don't think there is in the Philippines, but hopefully at some time it will happen. The nurse practitioner practice regulations have since been instituted and managed at the subnational level in these countries, Canada and the United States. And by 1979, there were approximately 15,000 nurse practitioners across the country. And to date in the US, according to the American Association for Nurse Practitioners, there are about 395,000 licensed nurse practitioners to practice in the US with a role to improve healthcare outcomes for patients. The educational preparation, I'm going to tell you briefly what it is. So educational preparation, you have to be a master's prepared RN. Preferably you've worked as a registered nurses for say about 2-3 years. That's highly recommended. And then lately we've instituted the Doctorate of Nurse Practice program, which is also recommended now to be able to hold out and practice as a nurse practitioner in the United States. We have to be credentialed and certified by 2 certifying boards. This is the American Association for Nurse Practitioners and the American Association for Certification for Nurses. I am under the AACN. I am board certified as a geriatric and internal medicine nurse practitioner, and I got this sometime way back in 2002. So I've been practicing as an NP for close to 2 decades. But before that, I've been an RN for over 20 years. So that speaks volumes because as a nurse practitioner, you have that experience. An NP practice autonomously in the United States, and this is state by state regulation. Certain states like California, we just started to push and legitimize our what we call full practice authority, wherein we can practice without the supervision of medical doctors. Some other states, they still have to practice under the supervision of medical doctors. Remember how nurse practitioners' role evolved? It came from the need to access healthcare, particularly in the underserved population. And so I do work once a week in an area where it's underserved, which is important because this is where the need for care are needed. There's very few medical doctors who'd like to practice in those areas. So this is where nurse practitioners actually work. So job description. So we have a variety of job description. It's so exciting because of my training and my background. I had worked in critical care as an RN. I had worked in emergency room settings. So I'm able to work in an internal medicine practice where I see my own patients. Also, I'm able to work in urgent care based on my experience in the ICU and emergency room. So in the US, all schools who provide nurse practitioner programs have different specialties. There's the acute care nurse practitioner. There is the pediatric nurse practitioner. You have the geriatric nurse practitioner. You have child or neonatal nurse practitioners. So there's different levels or credentialings for and specialties for nurse practitioners. Work settings. See, I am going to show you the work settings quickly, then I'm going to go back to this slide. So nurse practitioners can work in any of these settings: ambulatory centers, outpatient clinics, inpatient care, hospital-based practices, skilled nursing facilities and long-term care, medical group practice. One of my practices is actually a medical group run by nurse practitioners, and that includes myself. Home visits, and telehealth. So since COVID, the pandemic, the telehealth system of providing care had been established. And with the COVID pandemic, something nice really came out in the state of California. Our governor had authorized nurse practitioners to practice independently, which is hugely great. Like what I said earlier, each role of nurse practitioner is mandated by their governing board, the Board of Nursing, on how they could practice. So, for example, compared to Arizona, where our nurse practitioners in Arizona can actually hang their own shingles, meaning they can open their own practice because they're given that full practice authority. Whereas California, where I practice, just started this full practice authority law, where we can actually practice and have our own setting, our own, let's say, our own practice, our own clinic where we run it. This came about because of the pandemic. This came about because of shortage of family practice or family care physicians. Most of the physicians in the U.S. are actually doing specialty. So there is a need for the population to have access to health care, and they could reach to nurse practitioners. So the role of the nurse practitioners actually intertwines with with the role of medicine. So what is our role? Okay, let me finish this slide. So we can practice in universities, and we can also practice and work in pharmaceutical companies. So what can nurse practitioners do? So like what I said, our role intertwines between the practice of medicine and nursing. So we can and are able to perform histories and physicals, do examinations, order diagnostic examinations, which includes laboratory, radiology, x-rays, MRIs, CAT scans, and then formulate a diagnosis and an assessment based on those findings that you have on your H&Ps. And with that, you can create a plan with your patient that the patient agrees, and parts of the plan could also include prescribing medications. That's a huge responsibility for nurse practitioners in the United States, is to prescribe. To be able to prescribe, you have to have what we call the Drug Enforcement Agency authorization, and you have to take pharmacology courses to enable to perform this task. It's not easy, but this is what we do. And we can also order physical therapy. We can also have patients admitted to the hospital if it's something beyond us. And of course, we always collaborate with our medical doctors. That's part of our job. I myself work with an interdisciplinary group of providers. I work with physical therapists, respiratory therapists, nurse anesthetists, certified nurse specialists, and nurse leaders. So we talk about the care for our patient. Is not I'm not solely responsible for the care of my patient. This is an interdisciplinary care. So going back to the state-by-state regulation of what nurse practitioners can do, in the state of California, as of today, we still have to practice under what we call standardized protocol. So what is a standardized protocol? These are the responsibilities that what a nurse practitioner in a certain state can perform, allowed by the governing board, which is the Board of Nursing in California. So nurse practitioners can also conduct and perform research studies. One of my responsibility right now is I'm helping one of my former professors perform a research study on developmentally disabled older adults and their quality of life. And hopefully it can get published. So that's another role or opportunity that nurse practitioners can do is to publish. Nurse practitioners can teach. They can be professors, mentors, and preceptors for student nurse practitioners. And this is something I do on a daily basis. I precept nurse practitioner students in my practice. Nurse practitioners can advocate. We can lobby. I am a huge advocate for my patients. Recently, I was in Sacramento, the state capital of California, and we lobbied to push our NP, our nurse practitioner bill, even further, that we're able to hang our own shingles, open our own practice. And we were allowed by our governor to have this bill pushed into a law. Nurse practitioners can be policymakers. We can run for office. We can run as councilwomen, mayors of cities and towns, which is actually great because it's important we have a voice from nurses. Realize I'm still a nurse, regardless of what I do, that we are in the forefront of healthcare, and someone has to speak on behalf of our patients, and someone who's knowledgeable about the healthcare is able to speak up there in the government on what we can do, what services we can do for our patients. Nurse practitioners can open their own businesses, and nurse practitioners can be administrators. Let me go back to my other slide. So work settings, we discussed that. Legislations regulating nurse practitioner practice. So it's regulated state by state. Professional perks. Well, there's quite a few professional perks for nurse practitioners. Number one is, which is the most important and which is deeply, I'm very passionate about it, is to be able to take care of my own patient, meaning you are holding out as the person accountable for your patient care. They are looking at you like their healthcare provider, like their doctor. It's okay, they can call us doctor, but we always have to say, I am your nurse practitioner. I have the background of a degree. I can do a job and responsibilities that a medical provider, an internal medicine provider can perform. So part of my responsibilities that I do in my practice, other than performing histories and physicals, doing examinations, ordering diagnostic examinations, and making plans for chronic illnesses, is that if I work in a setting, one of the settings that I work as well is urgent care. Do simple procedures like pap smears or sutures or wound packings, casting, any orthopedic procedures, any non-emergent procedures. And when it comes to emergent procedures, it's always my responsibility to call and make sure that my patient is able to go to the room. We do a lot of communication with our doctors. And one of the perks too is that they treat us like their colleagues. We are treated equally. There's no one is higher or lower than anybody because we're so respected with what we do. So that's one of the perks, and which is huge. The other perks too is we're able to attend conferences, so we be updated on a lot of pharmaceutical, anything new, any medications that's new that we can prescribe. It's very important that we have to get updated because there's always new medications coming out, and we have to learn that. Other perks are like, okay, we can also be part of a speaker program or for a company, just like what I'm doing right now. So that's a perk. But again, the most important is that we are given that accountability to take care of our own patients. And my last slide is, I'm going to read it out for you according to the American Association for Nurse Practitioners, with a focus on health promotion, disease prevention, and health education and counseling, which is huge. This is a big part of nurse practitioners. Realize we're nurses, so we're very good in patient education. We're very good in counseling. Nurse practitioners guide patients in making smart health and lifestyle choices. to continue to provide that high level of patient-focused care and to continue to serve as a trusted, you see the word trusted resource for patients. Patients rely on us. So we have to be very careful on what we share to our patients, that they're evidence-based. Very important, evidence-based care into how legislative changes could affect your practice. The picture that I shared you on the right side of the slide is one of the opportunities that was given to me as a lobbyist with a Nurse Practitioner Association, wherein we can actually speak and meet with legislators, local and state legislators, and tell them what we do, what we can do for our patient, so that they're aware of what nurse practitioners, because what we do are huge and what we do matters. So in short, I would like to encourage you to have any questions later on what my role is or our roles as advanced practice nurses. Thank you for giving me this opportunity, and we'll talk again.
So we already got to hear the experiences coming from a certified registered nurse anesthetist and of course a nurse practitioner. We proceed with our next sharer for today. Our next speaker attained her Bachelor of Science in Nursing degree at the Far Eastern University, wherein she graduated cum laude. Her Master of Science in Nursing Clinical Nurse Specialist, Gerontology Minor, Nursing Administration, California State University, Dominguez Hills. Her certificate program in Quality Assurance, California State University, Dominguez Hills, and of course, her doctorate of nursing practice at the University of San Diego, California. Some of her affiliations include Philippine Nurses Association of Southern California, outreach programs, American Heart Association instructor, Healthy Heart, Healthy Family classes on heart disease, diabetes, and hypertension in different PhilAm communities, Advisory Council member at the PNASC, Parliamentarian at the PNASC Executive Board, Faculty Advisor at the UCLA SON Asian Pacific American Health Collaboration Access Resource and Education, and a faculty advisor at the UCLA SON APIN SAA. Without much ado, to talk about the topic and at the same time to share her experiences as a clinical nurse specialist, we have Dr. Emma Cuenca.
Good morning to you all in the Philippines. It is Wednesday evening here in Los Angeles, but I think it is Thursday there in the Philippines. Magandang umaga sa inyong lahat dyan. Thank you, Delex Farm Incorporated, for inviting me to speak in this panel. My objective today is to describe the clinical nurse specialist role and its three spheres of influence on patient, nursing, and organization. As part of disclosure, I'm not associated with Delex Farm International. This is a personal choice to accept the invitation to speak to you today. I do not represent UCLA as a panelist, as my presentation is not a UCLA-based work. This is sharing of my personal journey of my 30 years experience as a cardiothoracic CNS in the state of California. The CNS is one of the 4 advanced practice nurses in the United States. As mentioned by Dr. Yap, there are 4 advanced practice nurses here in the US. The nurse practitioner, we call them NPs. Clinical nurse specialists, we call them CNSs. The nurse anesthetist, we call them CRNAs. And the nurse midwife, we call them CNMs. It was in July 1, 1998, that the California Board of Registered Nursing put into law about certification of CNSs to practice in that role and to use the title. It is a protected title, meaning to use the title, it signifies that you have met the requirements by the California State Board of Nursing to practice as a CNS. Any registered nurse claiming to be a CNS and who practices as a CNS without the proper training and certification by the state board may result to suspension or revocation of the RN license. So all CNSs have RN license, and there are about 72,000 clinical nurses specialists in the United States. So as you could see, and as you have heard, each advanced practice nurse has each specific scope of practice, and that is created. That scope of practice is well written by the State Board of Nursing and the National Certifying Board. So what is the educational training of a CNS? A CNS training requires a master's degree in nursing from an accredited school of nursing. And, here in the United States, different schools of nursing offers different tracks of practice, such as gerontology, psych, critical care, palliative care, peri-op, maternal and child and neonatal care for the CNSs. It requires 500 clinical hours to complete the degree and requires a comprehensive exam or thesis to graduate. The terminal degree for a CNS is doctorate in nursing practice or doctorate in philosophy, which requires 1,000 clinical hours in their area of specialty. The certification for the CNSs is through the State Board of Nursing, and the renewal of that is every 2 years. And a CNS may also have a national certification by the American Nurses Credentialing Center. We call it in here ANCC, or the American Association of Critical Care Nurses. The certification typically costs about $250 to $340 if not a member of the specialty association. The renewal of the national certification is every 5 years, with 3 options, either by submitting an evidence of 1,000 practice hours during 5 years and 150 education points, or option 2, having 1,000 clinical practice hours plus retaking the exam, or option 3, having 150 CE points, we call it here, plus the exam. To practice as a CNS, there are 5 major sub-roles which must be demonstrated as competencies for certification. One, and this is basically a description of the job as a CNS. One, you have to practice as an advanced clinician and clinical expert. This is truly the hallmark role of the clinical nurse specialist. You are the advanced clinician and clinical expert at the bedside. The CNSs manage complex needs of patient population in the specialty of practice, uses advanced theoretical and empirical knowledge of physiology, pathophysiology, pharmacology, and health assessment. The CNSs assess and intervenes in complex care problems of patients, including the family, in the specialty area of practice. They coordinate patient care management with interdisciplinary team. The second sub-role is a consultant. The CNS provides clinical expertise and makes recommendations to the physicians and other members of the healthcare team in the management of complex care of patients. We review the standards of practice that reflect the translation of latest evidence in clinical practice. We evaluate policies and procedures in the unit level, reflective of current evidence in research. We are also performing the clinical leader sub-role. The CNS demonstrate mastery in theories of change, systems theory, negotiation, and conflict resolution, serves as a change agent in healthcare setting, and assists in the implementation of practice standards, and supports the achievement and evaluation of patient care outcomes. As Dr. Valerio and Dr. Yap mentioned, we have we are expected to join professional organizations and actively participate in its mission and purpose. So as you have heard, the panel today are all members of the Philippine Nurses Associations, and we have been in leadership roles of the organization as presidents, as legislator, as vice president, etc. The other sub-role is the researcher, an evidence-based practice change agent. The CNS uses clinical inquiry and research in an advanced specialty area of practice, has a key role in organizational changes using evidence-based practice and performance improvement model as avenues to improve advanced clinical practice. Facilitates journal club. We are the one who encourages staff nurses to review the literature and use the highest level of evidence to change practice at the bedside. And as an educator, we conduct staff development classes and courses, and serving as mentor or clinical mentor for those who are back to school advancing their degrees. So by evidence, the role of a CNS has made positive impact to three spheres of influence: patient, nursing profession, and organization. So to patients, the CNSs has provided evidence that their work at the bedside has decreased hospital stay, increased patient satisfaction, for example, on pain management, has decreased hospital-acquired infections, decreased ED visits, and hospital readmissions. To nursing, hospitals, units with unit-based CNSs have higher nurse satisfaction through clinical support at the bedside by the CNS. In UCLA Health, we have 24 specialized CNSs on board. And to the organization, the role of CNSs contribute to positive financial status of an organization through decreased length of stay and decreased HAIs, which the CNSs have much big impact to each achievement. The CNSs also facilitate with the unit managers passing accreditation visits by the Joint Commission and the Department of Health. And overall, it contributes to very good hospital ranking when you have good CNSs on board. So I just want to share with you my typical day when I was a practicing cardiothoracic CNS for 30 years in a flagship hospital, performing 21 cardiac surgeries every week. Before I joined UCLA School of Nursing. I always find joy and satisfaction with my daily works, as every day is a new day with different experiential opportunities. I joined the early morning cardiac surgery team rounds at 7 o'clock before the surgeons head to the operating room, and in the late afternoon for a huddle. During the cardiac surgery team rounding, the primary nurses present their patient's history, the latest hemodynamic profile of the patients, current problems, and current therapy on board. And during rounding, I hear all this report by the nurses, and I have a very clear picture on how to create a plan of care with them and with the intensivist. We review x-rays after the rounds. We look at the x-rays for presence of effusion and pneumothorax, and we create a full individualized plan of care for each patient and family. Fortunately, I have a very good, great collaborative working relationships with cardiac surgeons and intensivists that they truly respect my recommendations in a daily plan of care. And it's key to work as a successful CNS at the bedside. You need to have respect by the cardiac surgeons, in my case, and the partner physicians in other fields of practice. The bedside nurses always connect with me through cell phones provided to the CNSs or through the Vocera system so that the staff can reach me anywhere I am for consultation for complex problems like arrhythmias, ventilatory support, chest tube insertions, intra-aortic balloon pump management. Our cardiothoracic nurses are trained to manage emergency resuscitation, such as open chest procedure at the bedside for cardiac tamponade. So we manage our own codes. The intensivist and I typically lead the emergency resuscitation. Since we're only a door away from the OR, we just call the anesthesiologist if we need intubation. So it's pretty exciting day for me and for the nurses because we love our job so much. I provide just-in-time training for any staff who needs review in the operation and troubleshooting of a device or equipment like intra-aortic balloon pumps, CRT machines, devices like pacemakers. And we do yearly simulation of an open chest procedure so that the nurses are very well prepared for bedside open thoracotomy procedure. Our patient rooms are designed to convert an operating room for emergencies like open chest for cardiac tamponade. I attend situational awareness meetings in the morning as well and support unit-based practice council committee projects. The role of a CNS primarily for quality improvement is to really ensure that we are meeting our quality improvement initiatives like pressure injury prevention, early ambulation, pain management, and hospital-acquired infection bundles, implementation of the bundles. Also, of course, we participate in research and evidence-based projects and facilitates monthly journal club. In my case, in cardiac surgery, we train the staff nurses to take turn in choosing a research article to present in our monthly journal clubs and able to critique the level of evidence and quality of evidence on those articles. So the perks, just like what Dr. Valerio and Dr. Yep said, okay, it's the love and the passion for being an advanced practice nurse. It's not all about the money, but of course, it's nice to have, good pay. But CNSs are not paid as much as the NPs and CRNAs. But the best perks that I enjoy the most are the spheres of influence to patients, nursing, and organization. When you see positive outcomes on patients as they go home without complications in 5 days after a coronary artery bypass graft, and they're able to go home in 7 days after a valve surgery with no hospital-acquired infections and well-managed pain, that is a perk for a CNS. When your surgical mortality rate is one of the lowest and best in the country, that's a great satisfier and a good perk for us. When you see staff nurses happy and satisfied when they feel supported at the bedside by the CNS, that's another perk. And when you know you contribute to the organizational success, particularly the financial aspect of it, that is a perk. Because you get a bonus when you're meeting the hospital or the organizational initiatives. The CNSs are typically sent to national conferences, fully paid by the organization, especially if you're presenting as a podium speaker or a poster presenter of your research or evidence-based project or QI project. The CNSs are always the first one to test, evaluate, and make recommendations of new device, equipment, or programs. The CNSs are key stakeholder in decision-making for medical equipment choices. The salary ranges, of course, I don't want to divulge in here. I'm sure you guys can actually search the typical salary scale of a CNSs. But then again, it is very encouraging. One of the perks really is the support for advancing your degree. The hospital where I work, they offer $2,000 tuition reimbursement every year when you are back to school. So one of the perks also is when you have a very well put together CNS portfolio showcasing your years of experience, your value added influence to the spheres of influence that I mentioned, and you have measurable outcomes or deliverables that you have contributed to nursing and to a healthcare system, it can lend you a job as a chief nurse executive in a huge healthcare system or an academic position in a university. So I think that's all I have. I rushed through it. These are my references. And I really thank you for the opportunity for having me speak to you tonight or today. If I will not be able to answer some of your questions because of the time, here is my contact information. And again, mabuhay tayong lahat. Thank you po.
Oh, wow. At this point, we are still in celebration of our world-class Filipino nurses at the forefront of healthcare. Without much ado, we proceed with our fourth speaker for today. Our fourth speaker attained his Bachelor of Science in Nursing at the University of Santo Tomas, and at the same time, his Master of Science in Nursing, major in Nursing Administration at the University of Southern California, Los Angeles, California. Some of his affiliations include adjunct faculty at Lake Erie School of Osteopathic Medicine, adjunct faculty at the California Career College Prime, senior care service line staff at the Encino Hospital Medical Center, and of course the chief nursing officer at the Prime Healthcare Services, Sherman Oaks Hospital. It is with delight that we direct the spotlight to Nurse Roland Santos for the topic Nurse Leads.
Good morning. Good evening to some. And mabuhay tayong lahat. I know we have folks from all over the place. We have folks from Aklan, Abra, all the way to Zamboanga. So tonight, I'm going to share you my story. I'm going to be down to earth. And I don't know how I can compare with the previous speakers, but I definitely salute my speakers. And thank you for inviting me to this conference. And my topic today, of course, is guess who's managing all these operations in a hospital. Of course, we have what they call our chief nursing executive. Sometimes we call them chief nursing officers. I believe the common terminology is chief nursing officer. So some statistics for chief nursing officers. Of course, every hospital has to have a chief nursing officers. Currently in the United States, there's about 4,749 acute care hospitals. So, so each one of those has a chief nursing officer. Out of the chief nursing officers in those hospitals, according to the statistics, 68% are white, 12% are Hispanic, 10% are other races, and of course we have 6.8% Asians. So we got to do more, right? But this is good. 6.8% Asians in the countries such as United States. So also the other statistics shows that of the chief nursing executives in the USA, there's only 23% male chief nursing executives. So males inside the room. I know there's a lot of CNOs inside the room. And then, of course, 77% are female. So those are currently the statistics relative to chief nursing executives. So now my story. I want to share with you my story. My story starts, of course, from when or before I enrolled for nursing at the University of Santo Tomas. And I remember vividly that I applied for a fine arts program or, the course, or an architecture program or architecture course at UST. My family, though, said, please be a nurse. And I said, why do I want to be a nurse? And they say, you can go abroad. I think that's the something that people tell you many years ago. So I'm telling you my age, right? So I decided, okay, I'll give my family a chance to be a nurse. So I did. Enrolled at UST, finished at UST, and then 4 years later, I became a BSN grad. I passed the boards, and then back then there was a shortage of nursing. And by the way, the shortage of nursing is back again. It's a wheel, so we're back to the shortage of nursing. And so what happened then was I applied at an agency, And in 3 months, I was supposed to leave. And yes, I left with 10 other people to go to the United States in what we called back then, I believe, Northwest Airlines. People remember that, right? They don't exist anymore. So we were dropped off in Chicago, Illinois. That's where I started my career. I was there for a year. I worked in a telemetry unit. And then after being in that telemetry unit, I had a vacation in California, the sunny, beautiful Los Angeles, California. And during my vacation, my friend goes, "Hey, there's positions here. Apply in this hospital." So I did. There was 3 hospitals that were calling me for interviews. I went to this hospital in downtown LA. Immediately after the interview, because there was a shortage of nursing, the human resource person says, "You are hard. You can start." I said, "Well, I'm from Illinois." So a month later, I started working for the hospital. And then after working for this hospital, I started off, of course, as a staff nurse in a telemetry unit, progressing to be an intensive care unit nurse. And then 2 years, I was working at the bedside 2 years and actually progressed to being a charge nurse after 2 years. And at that point, there was a position open in one of the units in the hospital. It's a telemetry unit, actually, / critical care unit. They said, "Why don't you, be a manager for this unit?" Just like, it's a temporary position. So that temporary position became a permanent position. And it's unusual in the USA for someone to ask you, because usually in the USA, you would apply for a position. If you want a position, you would be applying for that position. So eventually I took the position and then actually loved the position and eventually got promoted to director of nursing. And then eventually hired to be or promoted to be a chief nursing executive. Currently, I've been a chief nursing executive for actually over 15 years. And I'll give you some numbers because these numbers tell you exactly the life of a chief nursing officer. I put number 1 because number 1 is the day, April 1, is the day I got hired as the chief nursing executive. It's like an April Fool's joke, right? April Fool. And 15 is the number of years I've worked as a chief nursing executive currently. 24/7, of course, is you're never off. You're on call 24/7 a day. So that means you are on call 547 days so far. 5,475 days so far continuously. I may go on vacation, but I have that cell phone or the email where people will have to email me and ask questions. So relatively, you don't have a day off. So 131,000 hours, 400 hours actually spent or being on call so far. So that's a lot of work for a chief nursing executive. It's really about how much you love it, how much passion you have for the position. So tonight, I'm going to talk about, as I talk about my life story, about some of the functions I do, some of the personality that you have as a chief nursing executive, and also the must-haves. And of course, relatively, the chief nursing officer, as you know, is the highest ranking nurse in the organization. Actually, in the USA, you're almost second to the chief executive officer. And you may ask a question, can a chief CNO be a CEO? Oh, absolutely. We've had a lot of CNOs that became CEOs or have become CNOs in the past. So to tell you exactly what's going on, I'll give you a snapshot of my day. And I actually pulled my day's work from yesterday and actually what I did all day yesterday to give you an idea of how things are or what I do in a day, right? Because sometimes you hear a comment where they say he sits in the office or, he's a CNO, he does not have any bedside or he doesn't know bedside. But let me tell you what's going on. So yesterday, my alarm went off at 5:30 in the morning. Of course, I wake up at 5:30. I have 2 dogs. I live in a condo, so I have to walk 2 dogs. I should be ready to drive to work, get myself prepared. Dogs eat, poop, pee at 6:30 because I have to drive at 6:30 because I have to be at work at 7. Now, you tell me why I want to be at work at 7 a.m. I want to be at work at 7 a.m. because I want to see everybody the shifts that are going home, the shifts that are coming on, and I'd like to talk to every single one of them, and I'd like to round on all the units. So exactly at between 7:05 or 7:15, I try to get report from the chief house officer, and she is actually responsible for knowing what's going on within the hospital, so that when I make rounds, I'm familiar with what's going on within the hospital. So I actually allowed yesterday, or daily actually, between 7:15 to 8:45 a.m., rounding on all units in the hospital, including ancillary and nursing services. And by the way, currently I am actually overseeing two hospitals. I'm overseeing Encino Hospital Medical Center as well as Sherman Oaks Hospital. One is 150 bed and the other one is 148 bed hospital. So between up to 8:45 is when I finish my round, and as I'm rounding within the hospitals, I talk to directors, I talk to staff, I get their concerns, what's going well, what's not going well, what are the tools you need to do your job well, and any concerns from anyone. So I try to harvest those things as I'm making rounds in the hospital. And so at 8:45, that's the only time I'm able to sit down, maybe get a bite or two, breakfast, and actually try to look at the email. Because if you don't look at the emails or check your emails, you will certainly have about 300 to 400 emails a day. And so if you don't check it 3 days in a row, can you imagine how many emails you'd miss for the day? Because we're also part of a hospital system. We have 4 to 6 hospitals in our system as well. So between 9 o'clock is when I have what I call the C-suite. I'm the C-suite person. You call them C-suite because anyone that has a chief in front of their names, they're called one of the C-suite members or executive team. So you're talking about chief controller, you're talking about CEO, and of course you talk about chief nursing executive. So between 9 o'clock and 10:30, since I have two hospitals, I have what they call the daily calls. And the daily calls really deals with the different directors, different nursing leaders, different ancillary leaders, care coordination management, and actually up to 25 directors for that call because I'm dealing with two hospitals. And then, of course, I do invite also physicians. And usually our physicians participate in what they call the safety huddles in the morning. And those safety huddles really deal with issues about patient, not issues, but things about patient throughput, challenges during the day. How can we deal with challenges during the day? What can we do better as a team? So it's a very collaborative meeting between 9 o'clock to about 10:30 when I finish the other hospital. And of course, it's participated by the chief medical officer as well. Immediately after that is when I go into the mode of the business side and the financial reporting. So on a daily basis, I get a financial report with the CEO on what's going on in terms of reimbursement, what's going on with patient access, what is going on in terms of denials, because in the USA, of course, there's different payers in the hospital. We call them Medicare, we call them HMOs, we call them PPOs. So there's different payers. And of course, it is usually a reporting of what's going on in terms of the financial status of the hospital. And then this is also the time you do talk about the productivity too. So at that point, it would be 11 o'clock. And at 11 o'clock yesterday, I was doing committee meetings and we had a medical staff committee meetings. And I believe we had a performance improvement committee meeting yesterday. So that brings me, of course, already 1 o'clock, which of course, I need to eat at least 5 minutes, right? Take 5 minutes. And I usually try to eat during the meetings so that I can make use of the time. And so at 1 p.m. at this point is when I make the calls, other team calls, other appointments that I have on my calendar. Luckily, I have someone who does my calendar. So any given day, I really don't know what's going on with my calendar. And thank God for my executive assistant. He's able to make sure that my calendar is not too crowded or not too hectic so that I'm not able to meet the deadlines. And then, of course, at 2 o'clock p.m., that's when I start my one-to-one meetings with either specific directors who have issues or concerns who needs to talk to me, because I opened that for them for them to be able to talk to me about their concerns about their units. So that's the time. And then by that time, I will have spent already 2 hours. Now it's 4 p.m., right? And 4 p.m., this is really open. I try to keep that open. I usually tell my assistant to keep that open because I want to make sure that this is the time where drop-ins can come, because my mantra is that we have an open line of communication. Anyone can walk in. Although if someone walked in the middle of a meeting, I would talk to the person. And then by this time, it is 5 o'clock. And at 5 o'clock, it's my time. It's my time to decompress. It's my time to look at my stuff. It's my time to file anything that I need to file. One of the things that I do or I like to do is scan all the paperwork. And I do that personally because I file them. Excuse my dog. And so I file them electronically so that I don't have any paper. So at the end of the day, I don't have any paper to really save or put in folders. Now it's 6 p.m. And you know what they say in the Philippines, low bat ka na, right? I'm definitely low bat at 6 p.m. though. So it's time for me to go, and hopefully it's time for me to go. Sometimes I stay. And then in between all those days, of course, I do have some teaching jobs. So I have some teaching schedules. In between, I do teach twice a week. So I squeeze them in after the end of the day. So that's what my day is. And looking at that day, it's, as you see with all the stuff I have to do during the day, there's some things, key functions that you see, right? You're looking at staff efficiency. As I'm rounding all over the place, I'm talking to the staff, I'm talking to the directors, I'm looking at how efficient are we in terms of our staffing, and is the staffing enough? Is there a shortage of personnel? And so these are things I need to take back so that we can do something about these things. And are there processes within how I'm seeing on the floors that need to be streamlined? And as I'm going around also, you look at, okay, are they meeting regulatory compliance? Are we not meeting regulatory compliance? What can I do to meet regulatory compliance? And of course, I talk about fiscal management because some of the roles I said is really looking at fiscal management. You cannot, run a hospital if your hospital is not making any money, of course, right? You got to make money so that you can pay people who work in your hospital. And then, of course, as I say, you have oversight of direct reports. And luckily for myself, I think I have a good group of direct reports, and I'll show you in the later slide about the direct reports I have within the organization. And definitely human resource management. Human resource management, how you engage your people, how you, the recruitment, retention, and all that will be part of human resource management, how people talk to people, how you make sure that the environment has an environment where there's openness as well. And then, of course, if there are any evidence-based practice that need to be introduced to the staff, those will be incorporated as well in your day-to-day activities as you talk to your educators about what type of evidence-based practice that need to be implemented, new technology, new computer system. And definitely I also bring anything to the C-suite, to the CEO, and actually to the corporate CEO as well about the things that we need for our local hospitals. And definitely service line development is an example of a function where you need to grow your business. You need to look at what business needs to be done for your hospital to make sure your hospital is surviving in this time of changing landscape in healthcare. And then, of course, metrics, performance improvement. We're responsible also for looking at those metrics. Are they reasonable? Do they need to be revised? How am I going to work with the team to make sure that they are meaningful, measurable for the whole team? And then definitely nurse-physician collaboration or CNE, physician collaboration. This is a time that you collaborate with the physician because as you guys all know, physician can take you down. So you want to make sure that you have a great collaboration with your physician. And that's why I intentionally put them in my meetings every single day so that we're very transparent with them. And definitely patient safety is a number one concern, as well as staff safety. All right, so personality. What type of personality should you have? Definitely, you need to have a vision, definitely a vision of what your organization needs to have or what your organization seeks to provide. You need to have critical thinking, quick critical thinking, so that you can make good clinical decisions and good administrative decisions as well. And of course, as I said, look at efficiency, and you need to be a quick thinker, as I said, and of course, very flexible. So it's important for you to be able to change your plans as quickly as possible to the best of the organization. And definitely accountability is a personality that you need to have. There has to be some sense of ownership. You also need to make sure that you instill accountability to every single one of your members or your directors. And communication skills and people skills. People skills is important. And sometimes we spend so much time with people management. And so it's important for us to have great people skills and communication skills. And definitely, I mentioned about decision making, and definitely you need to be, now you can make bad decisions. Yes, you can absolutely make bad decisions. And I have made bad decisions in the past. However, the best thing about making bad decisions is to accept the fact that you made a bad decision and say, I made a bad decision. Let us refocus our efforts. And of course, details. You need to be detail oriented. I don't mean micromanaging. There will be times where you micromanage, but you need to have really attention to details and a lot of details. And of course, your time management. As I said, your day is full, so you want to make sure you're using your time appropriately. You want to be able to prioritize, and you want to be able to problem solve quickly. And definitely fiscal management skills. And that's why one of the requirements in being a master's prepared is really on accounting and the business part of hospital. So I think one of the things you can do is being also an MBA, which I will discuss later. And then, of course, you have an organizational perspective, what your organization seeks to provide, what is the high-level overview of what you need to do for your organization or for your hospital. You need to be able to know how to analyze data, synthesize data, and be able to explain that data and provide explanation to data as well. And definitely risk management, because hospitals in the USA are very litigious. I mean, the patients in the USA are very litigious. So you want to make sure that any risk management issues you need to look into. And I told you about people skills. So food chain, where am I in the food chain currently? I'll tell you where I am currently in the food chain. This is actually one of the organization charts in one of the hospital. So this is the organizational chart. I hope it's clear to everybody. As you can see, the chief nursing officer, look at how many departments the chief nursing executive is responsible for. Almost more than half of the hospital. So this is the current trends in the USA, where the chief nursing officer is not just responsible for nursing, but responsible for overall operations of the hospital. So, all right. So this is a chief nursing officer. She's a female, but I use the cartoon for this one. So you need to be able to prioritize, and I think this is exactly how it looks. How you look when you are a CNE, and you must be able to do it well with grace. Look, she's smiling, and she should be able to do that. It takes certain personality to be really a CNO. And of course, how do you prepare for the C-suite position? Definitely, there are some education required to be a C-suite. Most of my colleagues who were before me had mentioned about what are the requirements for being, in their positions, and most of it is being master's prepared. And these are the some of the positions that you may need to be a chief nursing executive, chief nursing officer. You can be an MSN. and you may focus on administration, and then you can be also DNP, doctor nurse practitioner, to also be able to be a CNO as well. And definitely being an MBA will help you to become and understand fiscal management related to being in the chief nursing executive role. And most folks will take MSN, MBA to be able to merge those together, or you can get some certifications. And then, of course, you can take the certification course, the nurse executive certification, and this one will cement your understanding about the chief nursing executive role as well. All right. So that is me. That's my story. I hope you learned from my story. And just in parting, I would say, I'm not telling you it's going to be easy. Yes. And I'm telling you it's going to be worth it. And to me, it is worth it to be a CNE. It is it's very fulfilling. It's very gratifying. And for you to be a transformational leader, it speaks a lot. And I thank you guys again for giving me an opportunity to speak to you. I hope you learned from my story as a CNE. And thank you so much.
All right, there you have it, ladies and gentlemen. It's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am sure you have lots of questions to our speakers. To answer your questions, I would like to bring you back our speakers, Mr. Regalado Valerio, Ms. Velma Yep, Ms. Emma Cuenca, and Mr. Roland Santos, together with our moderator, Mr. Alfon Gilier Daga.
Thank you very much for that introduction, Brad Pitt. Wow, what a sight to behold. We have our 4 speakers all in one frame. Good morning here from the Philippines. I know it's good evening there. All right. So, by the way, we begin with our question and answer portion together with our 4 speakers. Please don't hesitate to go ahead and type your questions down in the Q&A box or in the chat box, and we'll gladly read them out for you. Our comments are pouring in. We have a comment coming from Apple Grace Corpus. This is one of the best among the best bunch of speakers. Thanks, Delex. Thanks, speakers. Proud to be a Filipino nurse. Wow. And of course, we also have another comment as well coming from Almira Ala. She says this 2-day event is really really has interesting topics for critical care nurses. All right, so let's go ahead and start the ball rolling. We have a question. I believe this could be raised to our speaker number 2, Dr. Velma Yep. Hi, Dr. Yep.
Hi.
All right, so we have a question that is directed to you. Nurse Paula is asking, is master's degree in the Philippines recognized in the U.S. as a tool to advance nursing practice? Again, is master's degree in the Philippines recognized in the U.S. as a tool to advance nursing practice? Your advice, Dr. Yep?
Hi. So this question could be answered actually by the 4 of us. My take on this, and correct me if I'm wrong, Dr. Regalado, Dr. Cuenca, Roland Santos, is that the educational preparation for a master's degree in the United States, particularly to practice as an advanced practice nurse, I think the curriculum of the school matters. So, and this is governed by the state board of nursing. If the school or the university in the Philippines matches that curriculum, I believe it is accepted. But again, I could be corrected. Any comments, Dr. Valerio, Dr. Cuenca, Mr. Santos?
Yeah, hi. I think I can respond to that question. As Dr. Yep said, the curriculum for master's degree are all reviewed and approved by the State Board of Nursing, particularly here in the state of California. So there are required preparatory work to get to advanced degree level. Primarily, the curriculum should show that you have good advanced physical assessment, pathophysiology, required courses on leadership, on pharmacology, particularly physical assessment, advanced physical assessment, if you will. And then it has to be Masters of Science in Nursing. And I think most of the masters in the Philippines is Master of Arts. Is that what is in the Philippines, Masters of Art in Nursing?
Yes, Dr. Cuenca.
Yeah, so I think that could be an issue because what they want is Masters of Science in Nursing, so that there's a very good component of clinical inquiry and empirical knowledge to research. So I'm not saying that the Masters of Arts in the Philippines does not cover research. I think you do, but the curriculum has to match the requirement by the board. So I am not discouraging people there in the Philippines to apply. It will be reevaluated anyway. And some of the courses that you may have taken back in the Philippines could be considered for the advanced practice level. And you may be required to attend the other classes that is necessary to obtain that degree.
And I would add that one of the perks, of course, in most hospitals is what we call our tuition reimbursement. So we're now offering tuition reimbursement. So if you decide to pursue a degree, then you will be eligible for that tuition reimbursement. And currently, of course, in this time of nursing shortage, we are actually some of the hospitals are offering loan forgiveness. As long as you stay in a hospital for a period of time, they will provide you with loan forgiveness from wherever, university you got your master's degree in the United States, and as long as you stay in that hospital. So those are good perks currently. So, and I know education is a lifelong learning. So look at everybody in my team. They have so many degrees as long as I can,
Thank you, Doctor. Thank you, Sir Roland. Any further thoughts, Dr. Valerio? Perhaps you might add something.
I totally agree with the three of them. Even bachelor's degree, they evaluate it anyway. There is also a system independent of the university where you are applying. It's called like the World Education Services. It actually evaluates all the courses that you have taken in the Philippines. But for sure, it will be evaluated, and it will be they will determine if it will be considered yes or no. So you just have to apply.
Thank you very much to our four speakers. I think that bottom line of all our sharings for this answer is that we encourage our fellow nurses to proceed and pursue with graduate studies. As what Sir Roland has said, education is a never-ending journey. So we study and pursue graduate studies, and we eventually escalate and upscale our nursing knowledge and skills. We have another interesting question. I believe we could direct this one to our speaker number 4, Sir Roland Santos. By the way, we say hi to your dogs. Yes. All right. So the question reads, what is the current status of the U.S. nursing shortage, and what are your strategies? As a chief a nursing executive or officer, what is the current status of the U.S. nursing shortage, and what are your strategies? Your thoughts, Sir Roland?
I'll be down to earth about that. It's horrible. It's terrible. Most of the hospitals now are experiencing a lot of shortage because of the fact that nursing are moving away from the bedside. They are pursuing advanced degrees, just like my colleagues here in the room. They are going to traveling assignments. The baby boomers are starting to retire. So we have that big chunk of baby boomers that are going away from the bedside. Most of the nurses have been hit hard with the COVID and decided to step away from the bedside like right away. I've seen young nurses resign and say, I can't do this. I'm going to resign. this is my last day. And so we are experiencing a major shortage. And that's why I was talking about some of the perks we're doing for our hospitals, and not just our hospitals, every hospital, loan forgiveness, tuition reimbursement. And the one important thing I want to tell everybody in the room is that we're back to immigration, green card. In fact, we're doing green card interviews right now, and we're offering green card to NCLEX passers. And I'm not here to deplete the Philippines for nurses, but I'm giving an opportunity, of course. In fact, I'm going to make a bold announcement today that our 4 to 6 hospital system is going to be in the Philippines, and I will be one of them. I'll be in the Philippines in November to do an international recruitment. And this is for green card. As long as you pass your NCLEX, it doesn't matter what state you pass. We will help you with your reciprocity for the nursing license. And so I'll be in Manila, possibly at the Sofitel Hotel, and I'll give you the dates. And so this is an opportunity. I've been doing a lot of Zoom interviews, and I'm not just doing recruitment for Manila, Philippines, but I'm all over the US. I mean, all over the world. So I'm also doing Zoom interviews to get those nurses here. And as I said, my goal is to not deplete our nurses, but to help our kababayans, because we may have a surplus of nurses as well. And of course, I cannot blame our nurses for the attraction to go to the United States. As Reggie said, right? Nurses make money in the United States, but we hope we're not in for the money, but because we're here for our patients and for our compassionate care. Okay, so yes, it's tough, but and challenging.
Thank you, Sir Roland. And I'd like to view it as not depleting nurses, but rather it's more on creating opportunities and making dreams come true. It's been, to some nurses, it's been years of hard work before they will be able to attain that dream. And thank you very much for bridging that gap for our fellow Filipino nurses to be able to fulfill their dreams.
Let me add, can I add
yes,
something?
Roland.
Yeah,
Yes,
I just need to add that the priority dates of the green card nurses are now current. So your time from application to the time that you get here will have been shorter. It's less than it's anywhere from 12 to 18 months. So thank you. Sorry.
Thank you very much. And we look forward to that, Sir Roland Santos. I'd like to direct this question to Dr. Regalado Valerio. Thank you very much, Dr. Valerio, for inspiring a lot of our fellow Filipino nurses who are currently joining us, especially with your talk. I'd like to ask, what were the challenges that you encountered before you became a CRNA? And perhaps this could also be applied to Dr. Velma Yep and to Dr. Emma Cuenca right after Dr. Regalado Valerio. So, Dr. Valerio, what were your challenges, po? Your thoughts?
So first and foremost, there are a lot of ICU nurses in the United States who wants to become a nurse anesthetist. They're lured because of the monetary reward. And you can imagine that specifically in California during my time, there's only like 2 schools. So one at Kaiser program in Southern California and one at USC. In each school, they only accept 15. So imagine there's like thousands, 500, 900 people who's applying. They will streamline to probably like 200. They will interview 70, and then they will accept 16 students. So I was first discouraged because first and foremost, I'm a foreign graduate, and I have a lot of insecurities. I have a thick accent, Filipino accent. So I said, probably I will not be able to get into the program. However, I just tried it like an ordinary Filipino, matibay ang loob. You just apply and trust your guts. And then through prayers, luckily I was accepted. In fact, when I was accepted, I was in the Philippines vacationing, and we are going to the Our Lady of Manawag in Pangasinan. That was so memorable to me. And I think up above there paved the way for me to enter the CRNA program. Another thing is you have to become an ICU nurse. Because in order to become an effective nurse anesthetist, you have to have a good critical care experience. That's why they only accept ICU nursing, ER nursing, neonatal ICU, pediatric ICU into the program. And during the program too, it's a very rigorous program too. 2 years, you cannot work. You have to be full-time nurse anesthetist student. So when I was working, I needed money. So I work at Kaiser for per diem just like once a week. And my program did not know that I'm working. I have to hide it. Otherwise, I might be kicked out of the program, but I still have to work with because I have my wife there, and we are expecting to have a child. So after clinicals on a Friday, I go straight to Kaiser Permanente to work night shift. So those were the days. And now, as I am talking right now, I just look back and I say to myself, what a roller coaster ride! It is totally worth it. It is very challenging, I have to say, probably discouraging. However, it is never impossible. So I encourage and I want to inspire each and everyone who wants to become a nurse anesthetist or an advanced practice nurse here in the United States to go for it. Chase your dreams. It's not impossible.
Thank you, Dr. Valerio. How about Dr. Velma Yep? We'd like to hear your story, perhaps.
Yes. So the question was, what were the challenges that we met? Okay, going through the master's degree program and being a nurse practitioner. So just like what Dr. Valerio had said, I actually started late. So, and it's very important, by the way, to have a variety of experience as a registered nurse before you enter the program of being a nurse practitioner or even being a nurse anesthetist or a clinical nurse specialist, because the program where I went to is very intense. I went to UCLA where Dr. Cuenca teaches as a professor. So the program is intense and they require us to devote our time full time. So the time I went back to school, my kids were in high school. So financially, it was also very challenging because I had to continue working as an ICU nurse and at the same time putting my kids to school. The time was so intense that I work, I take care of my family. So that was one of the huge challenges going to school. But again, I recommend for those, it's not too late to go back to school. Just like what Roland had mentioned, that learning is a lifelong process. So another challenge is, so when I went to school, went back for my master's to become a nurse practitioner, the expectations become different. Okay, the expectations become different from being a superb bedside ICU nurse to being a student again. You learn to be following what your preceptor says. You do not expect to be treated like an important ICU nurse or an ER nurse. You are going to be treated like a regular student. So there's a lot of pride to swallow, despite knowing that you've had lengthy experience as a critical nurse or ER nurse. A lot of humbling and also very daunting to be faced with professors and medical doctors, physicians who will challenge you. That's another thing. If you want to be an advanced practice nurse, you have to show up to show that you know what you're doing. So a lot of studying. You have to study a lot, long hours. You burn candles at night, then you have to go to work. So those are another challenges too. Hugely, it's a gratifying thing at the end. There's always a light at the end of the tunnel. So, challenges are there to work on, and you'll see your prize at the end. That's my take.
Thank you very much, Dr. Yep. And of course, we give our spotlight to Dr. Emma Cuenca.
Yeah, I lived through the aches and the pains of going back to school myself. I have to say to all the people in this conference that once you have a dream, you have always the possibility to achieve it. And it's upon you to make that road. And hopefully as you have heard us, nursing is a lifelong learning. My challenges when I was going for my doctoral degree is we are full-time, just like the rest of the panelists in here. We're working full-time, and then we're working as a student full-time. And in my case, financially, it's a big challenge for all of us. Going through a doctoral program, 100 grand is a lot of money to spare to get your doctoral degree, plus the time to drive back and forth. It's true for all of us. Dr. Yap came in here in UCLA and traveling back and forth as well. I traveled to San Diego 2 hours in the morning and come back at night, and at the same time work at 6 o'clock in the morning to go back to work as a CNS. So those are sacrifices, and those are challenges in life. But once you have that goal to achieve your goal, it's like priceless moment. And we are saying that you also can achieve it. And how to achieve that? Connectivity, connection with people, find the resources available, connect with some of us. If you're coming here in the United States, you have your contact number from us, and please connect with us. Even though you may not have the plan of visiting or coming to the United States, please connect with us, because those are critical. Connect with resources to find information that can lead you to your goal. So there are lots of challenges, and we can tackle those challenges, especially during this time of COVID. So.
Yep.
All right, thank you very much. By the way, I'd like to say to all the four of you that I strongly salute you. I am also an active officer of the Philippine Nurses Association here in the Philippines, and I salute you for being leaders and officers of the Philippine Nurses Association of America. In fact, I had the delight of being a moderator as well during the 13th International Nursing Conference and Global Summit last January. I was invited by Dr. Mary Joy Dia, and I'm really happy to be able to see the four of you on this virtual platform. With that, ladies and gentlemen, fellow nurses and frontliners, you heard all the four of them. Once again, please give it up for Dr. Regalado Valerio, Dr. Velma Yep, Dr. Emma Cuenca, and of course, Sir Roland Santos. Thank you very much to the four of you. Let's all together give them our warmest virtual round of applause. Yay! All right, so that concludes our panel discussion for this particular topic. Without much ado, we direct the spotlight once again to our ever-soothing host, Brad Pitt. Brad Pitt, take it away.
Thank you, our dear speakers and moderator. Now we would like to present you with this Certificate of Appreciation. This e-certificate is presented to Mr. Francis Gerard Alipio in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Virtual ICU, Improving Patient Outcomes, given this 26th of May, year 2022. Signed by Dr. Larry S. King, Program Director, J. De Reuter C. Oroseo, Chairman and CEO of Delex Pharma. Thank you, Mr. Alipio. This next e-certificate is presented to Mr. Regalado A. Valerio Jr. in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Certified Registered Nurse Anesthetist. Given this 26th of May, year 2022, signed by the same signatories. Thank you, Mr. Valerio. This next e-certificate is presented to Miss Velma Yep in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Nurse Practitioner. Given this 26th of May, year 2022, signed by the same signatories. Thank you, Ms. Yep. This next e-certificate is presented to Miss Emma Cuenca in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Clinical Nurse Specialist, given this 26th of May, year 2022, signed by the same signatories. Thank you, Miss Cuenca. This next e-certificate is presented to Mr. Roland Santos in grateful recognition and appreciation as speaker during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, with the topic Nurse Leads, given this 26th of May, year 2022, signed by the same signatories. Thank you, Mr. Santos. This e-certificate is presented to Mr. Alphon Gilier D. Daga in grateful recognition and appreciation as moderator during the 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, given this 26th of May, year 2022, signed by the same signatories. Thank you so much, Mr. Daga. And to our wonderful participants, this e-certificate is for you for completing the 3-hour of 4th Critical Care Summit for Nurses, world-class Filipino nurses at the forefront of healthcare, given this 26th of May, year 2022, signed by the same signatories. And to formally close this morning session, let us welcome one of the hardworking AVP for Sales Operations of Delex Pharma. Here is Mr. Tony T. Moraleda.
Thank you for attending our 4th Critical Care Summit for Nurses today. We hope that you have gained knowledge from the different concepts and experiences of being a world-class Filipino nurses at the forefront of healthcare. We would like to express our heartfelt gratitude to one and all, especially to our excellent lecturers who are working for the betterment of the world's health. Likewise, to our ICU faculty who are continuously guiding us develop such a program for the healthcare providers. Your dedication and effort in making this ICU forum for nurses successful are embedded in our hearts. We hope that the valuable information and best practices shared by our distinguished speakers will be a guiding light to your profession. Also, this added knowledge may pave the way to inspire you to think of new ways how to be the best partners in providing quality healthcare to your patients and customers. Secondly, Delex Pharma International Incorporated aims to bridge the gaps in critical care by providing quality and cost-effective medicines and medical devices to the greatest number of people. Our hospital sales representatives and district sales managers visiting you in your respective pharmacies, critical care units, operating theaters, and emergency rooms will ensure that they can fulfill these vital roles during their engagements with you. We hope to continue and grow the partnership with you to provide the best quality healthcare to all. Maraming salamat po.
All right, so ladies and gentlemen, in line with the closing message coming from Sir Tony Moraleda, we also grab this opportunity to say thank you to our speakers. First up, to Dr. Larry King. Once again, thank you very much, Dr. King, for gracing this event and at the same time giving your welcome message yesterday, along with the talks coming from Nurse Marvin, Nurse Michael, Nurse Tracy, and of course, Nurse Arsad. And for our second day, we heard the talk coming from Nurse Francis Gerard Alipio, along with the sharings coming from Sir Roland Santos, Dr. Emma Cuenca, Dr. Velma Yep, and of course, Dr. Regalado Valerio Jr. We also want to say thank you as well to the soothing voice of our host, Brad Pitt. And of course, the success of everything came about because of the work of the people behind this webinar. We have the strong team of Delex Pharma. We have Sir Asher, Tang, JL, and of course, Sir Rian. On this note, ladies and gentlemen, fellow nurses and frontliners, once again, it has been a pleasure hosting and moderating this webinar for you all. I am Nurse Alfon Giliardi Daga, a proud endoscopy nurse from the Eastern Visayas Medical Center, saying, maupay na aga Sinirangan Visayas, magandang umaga Philippines, and of course, good morning world. At this point, once again, we invite everyone to please direct your attention towards your screens as we all together take a trip down memory lane and have a recap with all the happenings of the 2 days. This is our same day edit. Enjoy.
Thank you for attending our 4th Critical Care Summit for Nurses today.
What if employees are not comfortable talking their concerns about their safety culture to their managers?
The best organizations actually has to have an open flow of communication.
To be running all the tests for ISTAT, which one do you need to prioritize?
So if you are going to run your CG4, Chem8, and your troponin, ideally you should always start with your CG4.
So the virtual ICU
This is a not-for-profit
Practice independently.
Okay na tayo.
Good luck everyone, day 2.
Good luck po. Good luck, Sir Alfon, and to our speakers.
From everyone, I want everyone to go ahead and type in the chat box, where are you located right now? All we have from Vigan, Benguet, Zambales. We have from Rizal, wow. We have Ma'am Virginia from Canada. We have someone from Riyadh, wow. Thank you for joining us. Irene is from Manila, yes. How did you become a virtual ICU nurse? I mean, is there a specific training for that?
Most virtual ICU nurse jobs require a number of years to be like a bedside ICU nurse.
This is like the PRC in the Philippines, the Professional Regulation Commission. The nurse anesthesia is provided, the certification is provided or facilitated by the National Board of Certification.
With the COVID pandemic, something nice really came out in the state of California. Our governor had authorized nurse practitioners to practice independently, which is hugely great.
At 5 o'clock, it's my time to decompress. It's my time to look at my stuff. One of the things that I like to do is scan all the paperwork.
May the research and evidence-based lecture be your instrument in achieving greater heights in your respective fields.
If you got some inquiries or questions for Delex Pharma, kindly scan this product and service inquiry form, and they will get back to you the soonest. And to get the latest updates and webinar schedules, please like and follow us on these social media platforms. And that's the end of our session. We hope to see you again for another learning session. Please stand by for the post-evaluation QR code that will be flashed on your screen in a while. This has been your host, Brad Pitt, saying thank you. Stay safe and healthy, everyone. God bless us all.